fibrillation as an initial arrest rhythm, including patients treated with an automated external defibrillator. Exclusion criteria: if the patient has signs of STEMI on the EKG, hemodynamic instability unresponsive to medical therapy, refractory ventricular arrhythmia, an obvious or suspected non-coronary cause of the arrest, and or suspected or confirmed acute intracranial bleeding, or acute stroke will be excluded in this trial. The baseline characteristics are as follows: almost homogeneous, no, with both arms. And what are the results? Surprisingly, the overall survival when you have a delayed coronary angiography versus the immediate coronary angiography, there's no statistical significance, no difference if you do a delayed coronary angiography or immediate coronary angiography based on this result, and it doesn't really affect the overall survival. Endpoints, now, as mentioned, the survival at 90 days, no clinical significance, except for the time to target temperature management. All of the parameters mentioned here, there's no difference between the two interventions, the immediate angiography and the delayed angiography groups. 1-year outcome from the Kaplan-Meier and the landmark analysis, actually there is no difference between the two. Also, in terms of the 1-year outcomes from the COACT trial, with the myocardial infarction, since the index of development of the myocardial infarction, any revascularization since index hospitalization, any PCI since the index hospitalization, CABG, PCI, or hospitalization due to heart failure, there's no difference now if we do the immediate or the delayed coronary angiography. Hence, the conclusion of this COACT trial in patients with ROSC after out-of-hospital cardiac arrest without signs of ST elevation MI, immediate coronary angiography was not found to improve survival at 90 days and 1 year compared to delayed coronary angiography. Patients allocated to immediate coronary angiography reached their target temperature later as compared to delayed coronary angiography. There was no significant difference in the rates of myocardial infarction, revascularization, hospitalization due to heart failure, or ICD shocks between the two treatment groups at 1 year. So that's the COACT trial. But in the sub-analysis of the COACT trial, we found out that upon ECG, once you have ST depression or T-wave inversion, that would entail a poorer prognosis. That's what the sub-analysis of the COACT trial would tell us. Okay, and other randomized clinical trial that came along, because here in the COACT trial, they only include those patients who have who can have a defibrillator, meaning once you have this trial would only include patients who have
We apologize. Currently, Mr. Espartero is having technical difficulties with his microphone. We will be on standby for his answer. So we will proceed first with the next question. This is addressed to Dr. Gerlan. So good day. This is from Dr. Viray. I understand that immediate resuscitation is critical for patient survival. Is there a consensus as to how we decide if it is too late to give a patient CPR? And is there a downtime from arrest to arrival at the ED? Thank you very much.
Hello. Yes, thank you very much for that question, Dr. K. And really, we would like, as I've shown in the slide, like to emphasize that the earlier that we institute resuscitative measures, especially bystander CPR and early defibrillation that will be the one that will increase survival for out of hospital cardiac arrest. And every minute that we lose when a patient goes into cardiac arrest is really already a dent on the survivability of the patient. So let me answer that question by really dividing the pre-hospital care interventions and the ED intervention. And I think that was also emphasized by our second speaker when he said that when only for patients that are resuscitated and brought to the definitive care facility can interventions such as coronary angiography can be instituted. So therefore, the pre-hospital care is the one that really will make a difference. No, so in terms of the downtime for cardiac arrest to the arrival of the ED, if we take the dispatch performance a while ago, which I mentioned, that is within a minute from the receipt of call, once the patient is recognized to be in cardiac arrest and has activated the EMS system, that actually already doubles the survival of the patient, and if you have brought the defibrillator at site, then that again increases the chances of survival. So actually, in terms of what is the downtime in itself, the time to, let's say, we're going to give up on this patient because we are not able to revive him already. The answer is, if we have already instituted the appropriate BLS and ACLS care. So if your system allows for ACLS to be brought at the scene, then that having a return of spontaneous circulation at the scene will actually be your parameter in terms of the time. So if you do not achieve pre-hospital ROSC, then the chances of survival is really low. So in our system where there is no ACLS care that is provided in the pre-hospital setting, so we now bring the patient to the ED. So now, even if it is just under, for example, 5 minutes, that 5 minutes where the patient does not receive any CPR, will also affect the survivability of the patient. So I think that is the gist of that is that in terms of the consensus of when we should discontinue CPR, will really depend on the clinical parameters that we have observed when we have received the patient in the ED, if there was no pre-hospital ROSC that has been achieved. Yes, Kay.
Thank you. Thank you, Dr. Faith. I think Mr. Espartero is already with us. So we'll be proceeding again with the first question. Sir Alfie, hello, good morning. For the question again, let me repeat it. In terms of the team dynamics in CPR, what is your advice on establishing team dynamics as quickly as possible, especially for the new hires, and also your advice on dealing with team members who are not yet well versed or familiar with the conduction of your CPR?
Hello, good morning once again. For those who are, the question is Did I hear it correctly, Miss Kay?
Sorry. Again, for the team dynamics in CPR, what is your advice on dealing with team members who are not yet well versed in terms of coordinating or executing your CPR, and also your advice on establishing team dynamics as quickly as possible, especially for the newly hired nurses or employees or healthcare workers? Thank you.
What I can, not an advice but recommendation for this, especially for new hires, they're lacking the experience. Though, just like for example in ER, currently we're having a lot of nurses who are new hires, and even if we had attended training already about BLS and ACLS, still that's not enough for us to be confident in responding to a code. So my recommendation for this is to do mock code drill. So rehearsal, repetition is very important for them to gain confidence. So just like what we do in ER, every time we have, we usually do this early in the morning where we're not that busy. So what we do in ER is we do mock code drill just to keep on repeating on how to respond to code. And with this, we can make them confidence by the time we are actually responding to a real code. So yeah, my recommendation here is to do mock drill at least once a week.
Thank you, Sir Alfie. We actually agree. In institutions, especially in the emergency setting, mock codes are actually regularly conducted for us to be familiar, not only for the nurses, but also for the residents and consultants as well, for us to be able to refresh in terms of conducting your CPR in the ET. So for our next question.
For our next question, this is directed at Dr. Rod Castro. Are there any options for hospitals with no cath lab from Dr. Dimagiba?
Hello, good morning. Yes, thank you for that very practical question. Because as we all know, not all hospitals has the capacity to cater patients who will be having coronary angiography. So for these patients, what we can do is to manage them medically. We have to give them the guidance directed therapy. You know? So what we do is to maximize the support post-arrest. So as we all know, as I mentioned earlier, the moment this patient would achieve ROSC or return of spontaneous circulation, that's very difficult actually to achieve. That even if, as I mentioned, even if this patient had a ROSC, there are only 10 to 30% survival rate. Okay, so if you don't have the cath lab, based on the trials, naman, no, and even if that patient is a high-risk non-STEMI, you can actually wait. Now we can actually wait, so we can just delay the possibility of angiography. We need first to do or target survival for this particular patient. However, if the patient is or has ST elevation MI and there's no way that the hospital is capable to do angiogram, well, dasal na lang talaga, especially in the provinces. However, if they can transfer these patients to a PCI-capable hospital, that would be better, as prognosis is better if we do coronary angiogram for ST elevation MI. Thank you.
Thank you, Dr. Castro, for your answer.
May isang question pa yata, Doktora. Ano ba yan?
Yes, Doc.
For your question for extending your
Another question.
Okay.
Dr.
Yeah.
Rod Castro from Dr. Babasa. Question for Dr. Rod Castro. For post-cardiac arrest patients who are NSTEMI, do you routinely do angiography, and when do you do it?
Okay, as mentioned in the co-arc trial, in the Tomahawk, and the sub-analysis of these trials post-arrest, they don't usually recommend routinely to do coronary angiogram once the patient has an STEMI. And also with the guidelines, as you can see in the algorithm, now consider NSTEMI only. Consider doing the angiogram if the patient has NSTEMI, if and only if they have high risk, high risk profile, as I mentioned in the lecture earlier, And one of these actually, if the patient develop acute heart failure, para persistent chest pain, etc. So if that would be the case, yes, we can do the angiogram, but it can wait. Now it can wait. It's not really immediate that we would do that if the patient has NSTEM. Thank you.
Thank you so much, Dr. Castro, for accommodating our questions and for your time. We thank you also, Dr. Gerlan and Mr. Espartero, for your time and for your lecture today. So for the other questions posted, we will be forwarding them to the respective speakers and they will be trying to accommodate and answer all of them. And we would also like to remind to please scan the QR code for the pre-test. It will be flashed in your screens in a while. So there, again, reminder to scan the QR code for your pre-tests. So for sharing their knowledge and expertise, we would like to give credit where it is due, and it is our pleasure to award these certificates to our speakers. The Certificate of Appreciation is proudly presented to Mr. Alfie Espartero for sharing his expertise during the virtual conference of our 28th postgraduate course entitled Ensemble, Concerted Efforts, Outstanding Outcomes, held on the 21st of July 2023 via Zoom conference. Undersigned, Dr. Rhea Guntalilib, Postgraduate Course Director, and Arnel Tolosa, Department Chair. We would also like to present the Certificate of Appreciation to Dr. Faith Mesa Gerlan.
Thank you.
Thank you, Doc. And to Dr. Rod Castro. So let us take a moment to have a message from our sponsors.
And once again, we'd like to thank our sponsors for their support in helping us host this event.
Partner, I can't believe that that is just the first series of the day.
Truly, some gems have been shared to us by our speakers.
Well, moving on to our next series, the emergency department today has seen a rising number of substance ingestions and harmful substance exposures.
Indeed, in the US, there were approximately 2 million calls to the 55 poison centers in the year 2021 alone. As a consequence, a fair number of those cases ended up coming into the emergency department, which is why it helps that we brush up on what we know and how to handle the poisoned patient in the emergency room. So we present our next series entitled Dyshemoglobinemias, when the globin carries the toxin. Starting off our segment for dyshemoglobinemias is the former administrator, manager, and head nurse of the Toxicology, Referral, and Training Center of East Avenue Medical Center. With his background of more than 10 years in the field of toxicology for nurses, with training local and abroad, there is no one more qualified to deliver this opening lecture on the initial assessment of the poisoned patient than our speaker. Let us all welcome Mr. Michael Anthony Rio Florido.
Hello.
Yes, sir, we can hear you loud
Okay,
and clear.
thank you. Thank you, ma'am. So I'm Michael Anthony Rio Florido, and I'll be discussing about the initial nursing assessment and management in the poison patient. For my objectives, I'll be describing the role of a nurse toxicologist in the initial nursing assessments in the poison patient. Number two, I'll be describing toxicologic interventions that can be performed by a nurse on the patient. And number three, I'll be outlining the subsequent nursing care plan of the stabilized poison patient or its disposition. So let's now go to the definition of terms. So toxicology, it is the study of the adverse effects of chemical, physical, and biological agents on living organisms. Toxicity, it is the ability of a substance to cause injury to a biological material. So poisoning or poison, it is any agent that is capable of producing deleterious effects in the biological system, seriously injuring function or producing death. So for toxin, so we have poisonous substances produced not just by plants, animals, and or bacteria. So we can see a number of toxins that is being produced by plants, animals, and bacteria. Animals, it's either land or sea creatures. So a toxicant is an agent capable of producing symptoms of intoxication or poisoning. And poisoning, it is an overdose of drugs, medicaments, chemicals, and or biological substances. Usually in toxicology, everybody thinks that it's just suicide. No, so usually patient comes in the ER with a lot of cases. Just spills, gas attacks, and any other substances that is hazardous to the body. So toxicology nursing. So it is a multidisciplinary branch of nursing that deals with the management of poison patients. So it provides a holistic and comprehensive nursing care management through minimizing mortality and morbidity from poisoning, through strengthening the competency of nurses at par with existing standards of training and care and responsive to the current needs of our country. So for the roles of a nurse toxicologist or an advanced practice nurse in toxicology, so nurses are vital to the continuity of the operation of poison control centers. So at the moment, the Department of Health Regional Poison Control Centers is experiencing a shortage of clinical toxicologists to meet the expanding services of the poison control centers in our country. So the nurses are able to provide the following services, which includes but not limited to. So they provide nursing care management to poison patients. So this usually falls under the inpatient referral that we get from our institutions. So usually we get referrals from the emergency department and the other wards. No? We also get referrals from the OPD. So usually we do assessment and then we do rounds for the patients. We provide toxicologic information to callers through our poison information unit. So this is a very vital area of any poison control center, the poison information service. So the nurses, they usually give expert advices to the callers. No? So we usually handle calls from other institutions, agencies, not just for clinical management, but for information on drugs and any other related topics to toxicology. So we also respond to toxicological incidents. So we usually do emergency health response, especially during chemical incidents, a deliberate or a non-deliberate release of any hazardous materials in the environment. No? So since 2010, I've been responding to different chemical incidents. So I think the most talked about or sensationalized chemical incident that I responded to was the 2 Surendra gas blast. I think that was in 2015 or 16. So it was because of an LPG. So we also participate in health and environmental assessments and monitoring. So we usually do health and environmental assessments per request of the community. So we usually go to the community so that we will be able to assess. We usually do environmental health impact assessment also. And then for the environmental monitoring, we do ambient air monitoring in the community and facilities. And lastly, we conduct relevant trainings related to toxicology and chemical safety nationwide. So for the nursing assessment, so this is what we usually do. So a good history taking is very imperative in toxicology for you to be able to plan the care or to plan the care of management of the patients. So you must know and you must take note the type and amount of poison. Is it a pharmaceutical? Is it caustic? No, is it a toxin? Is it a marine toxin, a plant toxin, and the amount of poison? So you would be able to know how to manage the patient properly. So the amount of poison, we are talking about the quantity of the substance or substances that was taken by the patient. It is very important for us to know, especially like for example, for pharmaceutical agents, we must know how many tablets or pills or capsules the patient took for us to be able to calculate for the toxic dose of each pharmaceutical agent that the patient ingested. Like for example, the patient ingested, for example, the patient came in the ER and then um, MDI siya. So multiple drug ingestion. So we have medicines that have multiple components. No, so we have to take into consideration, or we have to take note all the components therein for us to be able to quantify or to calculate for the toxic dose of each tablet. No, so it is very important to well, it is important, or it's better to overestimate than underestimate, especially like, for example, for patients who went in the ER and then the relatives will just present you the blister packs, empty blister packs. And then you, of course, the patient or the relative wouldn't know how much the patient ingested. So it's better to overestimate. Like for example, a patient came in and then the relative said that the patient ingested the whole bottle, or a whole bottle of a pharmaceutical agent. It's better to overestimate that the patient took the whole bottle, than to underestimate. So the time of exposure is also very important. No? So it's just the same with any trauma patients that comes in the ER. So you have to take note the noi, toi, poi, doi. No, the time of exposure is very important because some poisoning agents or substances has delayed manifestations. No, like for example, your paracetamol and your iron. No, so they have delayed manifestations. They have this what we call the quiescent phase. So usually the patient will come in the ER. They're okay, but after 72 or 48 to 72 hours, the signs and symptoms will be showing up. Like for example, what else? Like for example, if you will be giving a demulcent to a patient, no, especially right after ingesting a caustic agent, it is very important to note the time of the patient ingested the caustic agent, because you cannot give a demulcent at least after 1 hour to 2 hours post ingestion. Ideally, you have to give a demulcent or your egg whites, your raw egg whites, 30 minutes to 1 hour post ingestion. So we give demulcents to protect the intestinal lining so that it will limit the absorption of the poison. So mode of exposure, no? Is it non-accidental? Is it accidental? No? Or deliberate or non-deliberate? So intake of other substances. So most patients who comes in the ER, they usually take other substances aside from the main, no, from the main component of their actions. No, so usually patient will come in, they would ingest alcoholic beverages before taking something. No, so I had a case before. So the patient ingested Zonrox. So before the patient ingested sodium hypochlorite, he made sure that he was already intoxicated with an alcoholic beverage. No, so he took 6 bottles of beer before he completely ingested the half cup of Zonrox. No, it's better to know what the intake of other substances. Circumstances prior to poisoning. No, so what happened? No, so ito na talaga yung sinasabi nga namin yung toxicology. Toxicology is also chismisology. No, so talagang you really have to delve into the reason why the patient committed suicide or what happened. You know what I mean? So in my experience in toxicology, so the top 2 reasons why the patient comes in our ER, it's either they were reprimanded by the parents, or it's because of their love life. So current medications, is the patient taking any maintenance drugs? No, it might react or counteract anything. So it is very important. And of course, it will let you know if the patient has any comorbidities. No, it is very important to take note of that because the poison or the substance that the patient ingested might potentiate the poisoning. Past medical history. So is this the first time the patient went in the ER for a toxicological case? Is this the first time? Is this the second time? Is this the third time? No? Did the patient have any past history of operations, etc., etc.? And any home remedies taken. No? So this is very important. Usually kasi, especially in our institution, in my former institution, so every time, like for example, there are cases that parents would let their children or the patient or their patient drink milk. No? So it's their belief that it will stop the poisoning. No? So sometimes yung iba sa, like for example in the provinces, they would let the patient eat the coconut husks, no? What else? Sugar. So it is the most common misconception, no? Like for example, when you drink something, you have to drink 2 tablespoons of sugars, no? So in that case, don't let the patient vomit. So nasa katawan niya na yun, so let it be. No. So for physical examination, so this is very, very important, especially like, for example, when you are dealing with toxicological cases. Like you have to evaluate the general status of the patient. Like for example, you have to get is the patient well, no, etc. No? So you may also take the AVTU of the patient. You may take the sample, etc. You examine the skin, no? Especially like, for example, for patients with history of substances abuse. So you have to take into consideration that the patient might have skin marks or needle tracks or marks, no? So usually it only happens when the patient is addicted to heroin. So thankfully, I still haven't seen a patient with that. No, so usually, in my experience, we usually see patients who are dependent, no, with methamphetamine, marijuana, no. So madalang lang talaga makakita rin ng ecstasy or cocaine, no. So characterize odor of patient's breath, no. So usually may mga kaakibat na breath odor yung mga substances. Like for example, with cyanide, it smells like bitter almonds, no? But unfortunately, we cannot smell it. It's due to genetic composition. So usually mas nagiging ang tawag dito, mas na-emphasize yung smell ng bitter almonds, usually with Westerners, no? So for example, if the patient ingested isopropanol, it's fruity, yung breath odor niya. For methyl salicylate, like for example, yung mga, ang tawag dito, effervescent oil, no? So oil of wintergreen yung amoy. For sulfur dioxide, hydrogen sulfide, it's rotten eggs, no? Etc. So auscultate the lungs, no? So sometimes, you just really have to be very, very cautious, no? So usually RALs, it may be indicative of an edema due to pesticide ingestion, no? Isoniazid, no? Wala ng isoniazid poisoning ngayon. Usually opiates, beta blockers, or your tricyclic antidepressants, no? Or sometimes aspiration pneumonia due to kerosene because the patient has developed, what do you call this one? Chemical pneumonitis. So listen to the patient's heart, check the abdomen, the usual IPP, diba? IAPP, and do a complete neurologic exam. No? So this is very useful as a descriptive and prognosticating tool for patients with impaired level of consciousness, especially for substances or agents that may present with neurological effects. No? Like for example, your organophosphates or your nerve agents for any gas attacks. No? So your VX, your tabun, sarin, cyclosarias, Yeah, Soman, cyclosarin. So toxidromes, so these are signs and symptoms, no, which when taken collectively can characterize a suspected toxicant. So these are just some examples of those toxidromes. No? So this is your Alice in Wonderland toxidrome. So this may be manifested, especially if the patient is already having atropine toxicity, no? So like hot as a hair, the patient is hyperthermic, no, dry as a bone, blind as a bat, no? Red as a beet, so the patient is having flushed skin and mad as a hatter. The patient is already experiencing delirium. So in my experience, one or two signs or symptoms that may present, especially with, for example, with fever, we have to stop the atropine therapy right away, and then reassess the patient. This is the dumbbells. I think this is one of the most popular toxidrome that we know. No? So your diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, lethargy, and salivation. And last is your narcotic or the opioid toxidrome, no? Your CP3-3H. So for your toxicology nursing intervention, so we do external decontamination. No? So I really think that everyone's familiar with decontamination. No? So we usually send the patient to our decontamination unit, no? And then let the patient take a bath. No? So we usually use mild soap or your alkalinic soap. No? So it doesn't really matter if it's ivory, no, or Care, but for economical purposes, we usually prefer to use Perla, the white one, not the orange or the blue one. No, it is very important that you use alkalinic soap because it prevents from or it has to protect the skin because one of the mode of transmission of of poisonous substances is through dermal. No, so you have to keep your skin, or you have to keep the patient's skin intact as much as possible. So gut decontamination, no? So usually we do activated charcoal. It's either multiple dose or single dose, no? So it's very important to take note that 4 hours post ingestion, no? So the patient may not be you cannot hindi mo naman na kailangan magbigay ng activated charcoal because we all know that the gastric emptying time is after 4 hours. So it has already been absorbed, and not all agents are compatible with activated charcoal, like for example, your alcohol, your lithium, no, your paraquat, no, and some pharmaceuticals may not be excreted through the liver, so you don't need to give activated charcoal because there's a misconception that people will give activated charcoal every time that they hear that the patient has a toxicologic case. So that's not the case. No? So you should always take note of that. We only do multiple dose activated charcoal if the substance is undergoing your enterohepatic renal recirculation. No? So we usually do forced diuresis with mannitol, but I think it's not the practice. But if ever that you will be doing it, of course, you have to check for the urine insufficiency, no, for the output, no, everything for the color, no, especially the BP, no. That's the most important thing. We do alkalinization therapy with sodium bicarbonate, no, acidification therapy for like your vitamin C, no, in an ampule. No? So we usually give the acidification therapy for substance of abuse patients. For alkalinization therapy, it may also be given for substance of abuse patients, no? Especially kung merong abnormalities with their ABGs and with iron. Dialysis and hemoperfusion. No? So administration of antidotes. No? So it is seldom necessary in poisoning. Not all poisoning has an equivalent antidote. No? So it benefits the outweighs potential harm, and it depends on the clinical status or the laboratory results. So that's what we always say in toxicology. So we always treat the patient and not the poison. No? So if there's no equivalent antidote for the poisoning agent. So you might as well just give the patient supportive therapy. There. So for your disposition, no, so observation at the emergency room for at least 24 hours may be warranted. So we always say this, observe the patient at least 24 hours. No, even if the patient has normal, if kung hindi naman ano yung diagnostics niya, mas maganda pa rin ma-observe yung patient because as what I said earlier, there are substances that has delayed manifestations. So frequent reevaluation, no, it is very important. You just don't do rounds once a day. So we usually do rounds like for example, ilang bang shift ang nursing? So tatlo. So usually ngayon dalawa kasi 12 hours. So usually 3 or 4 as much as possible. No, psychiatric evaluation. No? This is very important for suicidal patients and substance of abuse patients. No? So sometimes the relatives of the patient may come off, agitated, especially when you say that the patient will be referred to a psychiatric consult. No, just tell them or to reassess them. It's better to be sure to reassess the relatives of the patients for counseling. As we all know, especially for suicidal patients, no, if they're not effective or if their suicide is not effective for the first time, they will repeat it over and over again until they get it right. So childhood poisoning, no? So evaluate for possible child abuse or neglect. And when this happens, you can report it to your VAUC. This is very important. Family counseling and education, physical or sexual abuse among women, no? Rape, sexual harassment, and of course, your domestic violence. I think this will be my last slide. So thank you very much.
Thank you, Sir Rio Florido, for your very elaborative lecture. So actually, we appreciated the part where you said that the history taking, right, partner, is essential for us to be able to elicit the the mechanism on how the patient took the
Yes.
tablets.
Definitely. Like a definitive way to treat and manage a patient who's undergone acute poisoning really needs a very thorough history taking.
Yes.
Agree. And actually, we also our favorite part is that toxicology is also chismisology.
Yes.
But on a
It's also
serious
my favorite
note,
part.
okay. But on a serious note, even as nurses, as EM residents, it's our part to be aware of what's happening in the ED. So thank you, sir.
Thank you, ma'am.
Thank you. So for our next lecturer, he is a practicing EM consultant at East Avenue Medical Center and supervisor at the Toxicology Referral and Training Center from the same institution. With his expansive amounts of speakership on various topics of toxicology before and even during the pandemic, it is a pleasure and privilege that we have him today to present the approach to the patient with methemoglobinemia and carboxyhemoglobinemia. Please welcome Dr. John Paul Ner.
Good day, everyone. I'm thrilled to begin this session on the critical topic in emergency medicine, the management of poison patients with particular focus on methemoglobinemia and carboxyhemoglobinemia. So let's start with a quick refresher on what toxicology is. In essence, toxicology is the study of harmful or poisonous substances, how they could affect our bodies, how we can diagnose these effects, and how we can treat those effects. Toxicologists are often unsung heroes in the emergency department, quickly identifying the toxic agents and guiding the team on the best course of action to mitigate harm to the patient. Focusing on our topic today, methemoglobinemia and carboxyhemoglobinemia, these conditions are rare but are significant forms of blood poisoning. Methemoglobinemia occurs when iron within hemoglobin is oxidized, reducing its oxygen carrying capacity, while carboxyhemoglobinemia happens when carbon monoxide binds to hemoglobin, thus preventing the binding of oxygen. Both these conditions lead to hypoxia and have serious and sometimes fatal consequences. While not commonplace, they do occur, and it's crucial to diagnose and treat them promptly and effectively. This presentation is designed to equip you with the knowledge to do just that. In today's session, we will delve into the comprehensive management of poison patients, starting from the initial resuscitation to eventual disposition. We will discuss each aspect of this process, including risk assessment, decontamination, supportive care, and the use of specific antidotes, specifically in relation to carboxyhemoglobinemia and methemoglobinemia. We'll also touch on the toxicology landscape in the Philippines, discussing the prevalent toxic agents, the unique challenges and strategies to improve the practice of toxicology in the country. We hope that this session will not only be an enriching learning experience, but also inspire the adoption of specialized toxicology training and practice in the Philippines. So thank you all for being here today. So let's dive into our topic. So this is the emergency medicine's general approach of a poison patient. So we have the initial resuscitation, the risk assessment, the decontamination, enhanced elimination and antidotes, supportive care and investigation, and disposition. The first critical step in the management of a poison patient is the initial resuscitation, following the ABCD approach. This structured method helps us remember important steps in order, ensuring that no critical aspect is missed. A is for airway assessment and management. Maintaining a clear airway is paramount, particularly in unconscious patients or those with decreased level of consciousness. Techniques could range from simple maneuvers like head-tail-chin lift to more complex interventions such as endotracheal intubation, depending on the patient's condition. Next is B for breathing and ventilation. Look, listen, and feel for breathing. Pay attention to the rate, rhythm, depth, and effort of breathing. Oxygen supplementation or even ventilatory support may be needed, particularly if carbon monoxide poisoning has occurred, which can interfere with the oxygen delivery in the body. C is for circulation and shock management. Assess the patient's pulse, blood pressure, and capillary refill time. Intravenous fluids and vasopressors may be required in the event of shock. Remember that methemoglobinemia could lead to tissue hypoxia, which might precipitate shock. Next is D for detect and correct. This is the part where neurologic assessment is made. Use the AVPU scale or Glasgow Coma scale to assess the patient's level of consciousness. Patient with methemoglobinemia may present with seizures due to inadequate oxygen supply to the brain. Finally, E stands for exposure, meaning you must remove the patient's clothing to look for signs of poisoning such as burns, unusual odors, or discoloration. It also refers to reducing further toxin exposure and enhancing its elimination when possible. In the context of methemoglobinemia and carboxyhemoglobinemia, quick identification of the conditions is crucial. For instance, if a patient presents with a history of exposure to certain drugs or chemicals like aniline dyes or nitrites for methemoglobinemia, and for carboxyhemoglobinemia, it's exposure to carbon monoxide, along with compatible symptoms, this could be the key to quick diagnosis and prompt and effective treatment. Let's remember the ABCD approach is not just a set of steps, but an ongoing process. A poison patient's condition can change rapidly, and we must be ready to reassess and intervene at each stage. Risk assessment is a pivotal part of the management of a poison patient. Our goal is to anticipate the possible progression of the patient's condition based on their unique exposure and symptoms. Several factors influence the toxicity of a poison. Always consider the worst case scenario when conducting the risk assessment. The dose, of course, is paramount, so the basic tenet of the dose makes the poison still holds. However, the route of exposure also plays a significant role. For instance, inhalation often leads to a faster and more severe symptoms than oral ingestion. Individual characteristics matters too, like age, underlying health conditions, and even genetic factors can affect how a patient reacts to the poison. For instance, patients with G6PD deficiency are more susceptible to methemoglobinemia when they are exposed to certain drugs. Identifying the severity of methemoglobinemia and carboxyhemoglobinemia based on signs and symptoms is crucial. Mild methemoglobinemia might only present with cyanosis, while severe cases can cause dyspnea, chest pain, seizures, or even death. Carboxyhemoglobinemia can cause a wide range of symptoms from headache to dizziness to unconsciousness, depending on the concentration of carboxyhemoglobin in the blood. One useful tool for risk assessment is the poisoning severity score. This tool helps us quantify the severity of poisoning, aiding in the management decision. The score ranges from 0, meaning no symptoms, to a high of 4, meaning fatal. Toxidromes, these are collections of symptoms related to a particular class of poison, can also assist in the diagnosis and risk assessment. For example, the cherry red skin color is a classic sign of presence of carboxyhemoglobin, while the chocolate brown blood is a well-known indicator for methemoglobinemia. Through understanding these factors, we can make more accurate predictions about the patient's condition, guiding our management strategies. So after the initial resuscitation and risk assessment, we move to the next critical steps, the decontamination, enhanced elimination, and use of antidotes. The aim of decontamination is to prevent further absorption of toxin into the body. Gastrointestinal decontamination is the most common method, and it involves techniques such as the use of activated charcoal and gastric lavage. Activated charcoal is given orally or via the nasogastric tube. This binds many toxins, preventing their absorption. However, it should be given within an hour of ingestion for maximum effect. Gastric lavage, this is when the stomach is washed out with saline solution, is another method. However, its use is controversial and generally reserved for severe life-threatening cases of poisoning, provided that it can be initiated within 1 hour of ingestion. Now let's talk about enhanced elimination. These techniques employed increase These techniques are employed to increase the removal of toxins from the body. So some methods include urine alkalinization, which increases the elimination of certain drugs, and the use of multiple dose activated charcoal, which can enhance the elimination of drugs by interrupting the enterohepatic or enteroenteric circulation. Specifically for methemoglobinemia and carboxyhemoglobinemia, decontamination and enhanced elimination methods are usually of limited use. This is because of the condition. They are typically caused by inhalation or parenteral exposure, or by the body's own metabolic processes, not by ingestion. The primary interventions for these conditions are specific antidotes and supportive care, which we will discuss later. So remember, every decontamination and enhanced elimination method has its risks and benefits, and the decision to use them should be based on the patient's condition, the nature of the poison, and the timing of exposure. Now let's talk about antidotes. Antidotes are substances that counteract the effect of the poison. So methemoglobinemia can be treated with an antidote called methylene blue, which helps reduce the methemoglobin back to hemoglobin. However, It's important to note that methylene blue should not be used in patients with G6PD deficiency as it can cause severe hemolysis. If methylene blue is unavailable, ascorbic acid, yes, vitamin C, can be used, although the response is less marked and dramatic. It may be also considered the first line of treatment in patients with G6PD deficiency. So a daily dose of 1 to 2 grams may be given intravenously, followed by oral doses of 300 to 600 milligrams in divided doses. In cases of carboxyhemoglobinemia, hyperbaric oxygen therapy is the antidote of choice, particularly for severe cases or those with significant neurologic symptoms. By increasing the pressure of oxygen, reducing the half-life of carboxyhemoglobin, and improving oxygen delivery to the tissues. This will be discussed further by our next speaker, Dr. Ramos. Once we have taken steps to control the immediate threats and minimize further toxin absorption, we now focus on the supportive care and investigation. It involves treating the symptoms and maintaining basic functions of the body while it recovers. For instance, in patients with carboxyhemoglobinemia or methemoglobinemia, supplemental oxygen might be needed to combat hypoxia. In severe cases, mechanical ventilation manage any complications like seizures or arrhythmias. Further investigations might be necessary for poisoning cases involving the unknown or those that have challenging presentations. Both supportive care and antidotes form the core of the treatment for poison patients. The aim of which is mitigating the symptoms, preventing complications, and helping the body eliminate the toxin. A simple bedside test for methemoglobin determination is the filter paper test, where 1 to 2 drops of blood are placed on a white filter paper, then evaluated for color change upon exposure to oxygen. So this can be accelerated by gently blowing supplemental oxygen into the filter paper. The oxygenated hemoglobin changes from dark red to violet or bright red, whereas methemoglobin remains brown. So a normal blood can contain 1 to 3% of methemoglobin, while those with significant methemoglobinemia has chocolate brown blood and usually contains 15 to 20% or even higher of methemoglobin. Smokers usually have a higher level of methemoglobin. One modality in the evaluation of methemoglobinemia and carboxyhemoglobinemia is pulse co-oximetry. So this is a non-invasive procedure or modality. So this pulse co-oximetry is used to measure the methemoglobin saturation or the SPMet and the carboxyhemoglobin saturation or the SPCO. So these values are derived from specialized pulse oximeters. So these specialized pulse oximeters operate by using multiple wavelengths of light to differentiate the different forms of hemoglobin. So this enables us to non-invasively estimate the levels of these various forms of hemoglobin. So researchers has demonstrated that these pulse co-oximeters can accurately detect elevated levels of methemoglobin and carboxyhemoglobin, particularly in symptomatic patients. However, it's important to note that the accuracy may vary depending on the specific device used and in patients' factors such as the skin pigmentation and the presence of other dyshemoglobin. While this pulse co-oximetry is exciting development in the field, it should be used as an adjunct to rather than a replacement for the traditional diagnostic method, which is the arterial blood gas with co-oximeter. So as with any diagnostic tool, clinical correlation and interpretation within the context of the patient's overall presentation are critical. Now, the final steps in the management of a poisoned patient is deciding on their disposition. So this refers to whether the patient can be discharged or needs to be admitted to further care or requires critical care. The decision is based on several factors, including the patient's clinical status, the nature and severity of the poisoning, and the anticipated clinical course, and also the patient's social situation. In cases of methemoglobinemia and carboxyhemoglobinemia, the decision can be particularly challenging due to the potential for delayed or persistent neurological symptoms. A patient with mild symptoms who has been treated effectively could be discharged with close follow-up. However, patients with severe poisoning, persistent symptoms, complications, and high risk of deterioration should be admitted. Those with life-threatening symptoms and complications may require critical care. Risk stratification plays a key role in the decision-making process. Patient's risk category can be determined based on factors like severity of the initial symptoms, response to treatment, and underlying health conditions. To give a prognosis, we look at the combinations of clinical findings, lab results, and response to treatment. For instance, with effective treatment, the prognosis for most patients with carboxyhemoglobinemia and methemoglobinemia is good, though there are risks of neurologic complications in severe cases or if there is delayed treatment. The decision on disposition requires careful clinical judgment, a thorough understanding of the poison involved, and careful consideration of the patient's individual circumstances. Now, let's focus our discussion closer to home and look at the unique challenges and issues of poisoning and toxicology in the Philippines. So in our country, common toxic substances vary depending on the region and the lifestyle of the population. So in rural areas, pesticides, especially organophosphates, are a common cause of poisoning due to their wide use in agriculture. In urban areas, household substances like cleaning agents and pharmaceuticals are more frequently involved. However, methemoglobinemia and carboxyhemoglobinemia have unique causes. Methemoglobinemia can result from exposure to certain local medications like your benzocaine or your dapsone. Carboxyhemoglobinemia often results from carbon monoxide exposure, which occurs due to faulty household appliances or maybe during the disaster situations where people use generators. These are also challenges we face in managing these cases. So limited resources in rural or remote areas can make it difficult to provide timely and appropriate care. So in the Philippines, we have a lot of GIDA areas. Okay? So lack of awareness about poisoning prevention and management among the general public and health professionals is also a concern. So additionally, we have a lack of toxicology specialists and facilities, especially outside the major cities or more of these facilities are in urban areas. These challenges highlight the importance of education and training in toxicology for our healthcare practitioners, as well as public education campaigns about poisoning prevention and first aid. As we go to the end of our discussion, let's talk about the toxicology training and practice in the Philippines. So currently, toxicology education in our country is primarily embedded in medical and the pharmacy curricula, but it's limited and not standardized. So we have very few specialized toxicology training programs and a shortage of board-certified toxicologists. Moreover, toxicology is not a really popular specialty. So it leads to a fewer professional pursuing this field. However, specialized toxicology training has clear benefits. So it equips the healthcare professionals with the knowledge and skills needed to promptly and effectively manage poisonings. It enhances the quality of patient care and can help to reduce the morbidity and mortality from poisoning. Moreover, toxicologists can play a key role in public health by contributing to poisoning prevention efforts and conducting researches in toxicology. So to enhance toxicology training and practice in our country, we need multifaceted strategies. So this includes introducing standardized toxicology curricula in the medical school and in the pharmacy course. Okay? So establishing more specialized training programs and advocating for a recognition of toxicology as a distinct specialty. So we also need to raise awareness about the importance of toxicology among healthcare professionals and the general public. These efforts require collaboration among various stakeholders, including educational institutions, the healthcare institutions, professional societies, and even the government. So with the concerted effort, we can build a robust toxicology infrastructure in the Philippines and hopefully improve the care for the poison patients. Now, let's wrap up our discussion with some key takeaways. So we've learned that the comprehensive management of poison patients, like those with methemoglobinemia and carboxyhemoglobinemia, involves a systematic approach. So it starts with initial resuscitation and risk assessment, followed by decontamination and enhanced elimination when appropriate, then the use of antidotes and supportive care. Finally, careful consideration is needed when deciding the patient's disposition. We've also learned about the unique challenges in poisoning and toxicology in the Philippines, which includes a wide variety of toxic substances and the lack of resources for managing these poisoning cases, especially in the rural and remote areas. Finally, we've discussed the critical role of specialized toxicology training and practice. With more professionals trained in toxicology, we can not only improve the care of the poison patients, but also contribute to prevention effort and research in toxicology. So while the management of poison patients can be complex and challenging, with the right knowledge and skills, we can make a significant difference in this patient's outcome. Therefore, it is crucial that we continue to advocate and invest in toxicology education and practice in our country. So thank you for your attention. I now pass the virtual floor to the next speaker, Dr. Ramos.
Thank you very much for that very detailed lecture on carboxy and methemoglobinemia. It'll be sure to leave us just a little bit less breathless when trying to deal with these rare cases.
And we agree that we should raise awareness in terms of these conditions. Especially, we should also be especially wary because, as per the lecture of Dr. Ner, the substances that could cause these diseases can be found in the household with the household appliances and then your cleaning agents. So we highly appreciate it. Thank you very much, Dr. Ner, for your lecture.
And now, let us dive deeper into the management of dyshemoglobinemias. Specializing in diving medicine since 2001, he completed his studies in hyperbaric medicine from the University of Texas. His ascent in the field led him to be the acting section head and fellowship coordinator at the Center for Diving, Hyperbaric Medicine, and Difficult Wounds at the Department of Emergency Medicine in Southern Philippines Medical Center. Please welcome Dr. Jeffrey Ramos.
Good day, everyone. My name is Dr. Jeffrey Ramos. I'll be talking about the role of hyperbaric oxygen therapy in dyshemoglobinemia. I'm the section head of the section of hyperbaric medicine under the Department of Emergency Medicine in the Southern Philippines Medical Center, Davao City. So the objective of this talk is to discuss the role or the potential role of HBOT in this hemoglobinemia, hyperbaric oxygen therapy for CO poisoning. I'll talk more about this, and a brief discussion about hyperbaric oxygen therapy and some evidences in regards to this hemoglobinemia. Okay, so we'll be talking about this hemoglobinemia. So these are the species of hemoglobin that competes with your oxygen, thereby choking your cells, creating problems in intracellular respiration. And we'll be talking about carboxyhemoglobin in more detail and some information about soft hemoglobin as well as methemoglobin. So I have charted here a quick comparison on the different types of species, and the main problem of all these species is actually hypoxia, and it affects the intracellular level and escalated into the end organs, particularly your central nervous system and your cardiovascular system. And if it's just too much of this toxic hemoglobin, patients can die. At the moment, there's already an established management for this. For carboxyhemoglobin, it's oxygen. For methemoglobin, you have your methylene blue. For soft hemoglobin, you have your nitrites. And for carboxyhemoglobin, the Undersea Hyperbaric Medical Society, as well as the other societies in different types in different countries, has already accepted as hyperbaric oxygen therapy for moderate to severe carboxyhemoglobin. While for methemoglobin and soft hemoglobin, it's an adjunctive therapy for the standard management. Okay, so let us establish the poisoning. So the first objective is to prevent hypoxia. And the secondary effect is to prevent the late damage created by this acute hypoxic condition. Again, it is the most common cause of poisoning, either accidental and deliberate. We don't really have an exact data in the Philippines, and it's caused by several factors, and some of it is because of exhaust from your car or smoke from fire. And in the diving medicine or hyperbaric medicine, concern is about the intake of gases from your exhaust system from your cars and motorcycles taken into our hyperbaric exposure. I have an illustration by Dr. Lynn Weaver. The mechanism of action of carbon monoxide poisoning is quite complex and poorly understood. It's a combination of different factors actually, but the initiating factor is hypoxia, then there is cellular disruption and some inflammatory and immunological response because of this event, and the later, which is being manifested by some of our moderate to severe patients. The usage of hyperbaric oxygen therapy and carbon monoxide poisoning was first used long time ago in the 1940s by Dr. End and Dr. Long. Actually, they've started to use hyperbaric therapy for these toxic gases. This is the second indication, and the first indication is diving accident. There's a couple of anecdotal reports in regards to this, but at the moment we have 6 RCTs with conflicting reports. But even then, the most RCTs suggest that hyperbaric oxygen therapy is superior versus oxygen breathing at sea level, basically in the effect of neurologic stimuli. So now because of the previous RCTs that has a conflicting result, no? The one in Melbourne actually is a very interesting one because there is no difference between the outcome of hyperbaric oxygen therapy and 100% O2 for 3 to 6 days. So the society came up with a category of indication that not all patients exposed to carbon monoxide poisoning requires HBOT. So the mild ones don't need any. A normal baric oxygen or sea level oxygen with a tight fitting mask should be fine. And the ideal treatment time is still within 6 hours, which is pretty much the same as the indications for ischemic or hypoxic insults. Either it is from trauma or from decompression sickness. No? And as far as I know, most hyperbaric unit don't treat CO poisoning beyond 24 hours duration because again, the outcome is just the same. No? And the current studies suggest that there is a benefit when treating CO with hyperbaric oxygen therapy 3 times within the 24 hours duration. Okay, so since hyperbaric oxygen therapy is not an indication for mild CO poisoning, then the Undersea Hyperbaric Medical Society has established that HBO is indicated for moderate to severe patients, particularly those who has a neurologic presentation and those who has a cardiac involvement, as well as those pregnant women, even if their carboxyhemoglobin level is normal, we don't really know what's the value in the fetal circulation. So it is an indication for them because carboxyhemoglobin can be fatal or toxic to the fetus, as well as it has a teratogenic effect. Also, for those who has a persistent elevated carboxyhemoglobin of more than 25%, those patients also needs to be in a chamber. The advantage of hyperbaric oxygen therapy, I think, is the key word is plasma dissolved oxygen. It is governed by Henry's law. While you are seated here, there is a minuscule amount of oxygen that is dissolved in your plasma. Now, if we are getting inside a chamber pressurized at 3 atmosphere, your plasma dissolved oxygen is increased further. And with that plasma dissolved oxygen, it can actually preserve your ATP and maintain your cellular respiration. And the other advantage of HBOT is the accelerated elimination of your CO. For example, at sea level oxygen, the half-life is 80 minutes. But when you subject your patient to HBOT at 3 atmosphere, the half-life is 23 minutes. So it's very common experience that around 30 minutes during treatment, your patients will be awake. So you have to make sure that you can control your patients. You have to be able to continue with your sedation, or if not, continue with your anesthesia. Okay, as we said, that the mechanism of injury of CO poisoning is complex and poorly understood. There seemed to be an initial insult of hypoxia, then cellular metabolism is disrupted, resulting in inflammatory and immunological changes, and the net effect is tissue injury. But one thing stood out during the animal and human studies, in that HBOT was found to inhibit leukocyte function and cell adherence to the cerebral microvasculature. And this form of injury is mediated by leukocytes. And the resultant brain lipid peroxidation did not develop if the leukocyte adherence was inhibited. And the inhibitory effect of HbO2 on beta-2 integrin is observed if the pressure is beyond 2 atmosphere. We don't usually go beyond 3 atmosphere because 50% chance of hyperoxic seizure is a concern. The inhibitory effect of HbO2 on beta-2 integrin function has also been shown by the works of Zamboni in a skeletal muscle ischemia perfusion model. All right, after this lecture and after you are convinced that we can use hyperbaric oxygen therapy for our CO patients, and you have a freestanding hyperbaric facility in your hospital, I would suggest you go and visit them and talk to the hyperbaric physician and see if you can refer patients to them. But first and foremost, patient safety is critical. Okay, There's a choice between a monoplace hyperbaric chamber versus a multiplace hyperbaric chamber. A monoplace hyperbaric chamber for critically ill patients can be more technical versus the multiplace chamber. That picture there is our hyperbaric chamber. It's a multiplace hyperbaric chamber. The patient is not a CO poisoning patient, but I just put it as an example that we have a critical care capability for to manage these types of patients. No? So we have hyperbaric ventilators, we have monitors and everything that you need inside the chamber. Now, this is very critical. You cannot just bring in your emergency department cardiac monitor inside because it's not rated for a hyperbaric environment. It's a fire risk. You might have some fire and explosion inside the chamber, and that's going to be catastrophic for everyone. Again, the level of training of your medical and nursing staff should be identified, as well as the presence of your respiratory therapist is also crucial. Okay, let's talk about hyperbaric oxygen therapy on the sideline. The Undersea and Hyperbaric Medical Society, as well as the other societies in different continents, has agreed and defined HBOT as a breathing of near 100% oxygen, at least 95% medical grade oxygen, more than 1 atmosphere absolute pressure inside a pressure vessel constructed for that purpose. All right, the international community of hyperbaric practitioners, the Americans, the Australians, Japanese, Europeans all supported the delivery of pressure between 1.9 to 3 atmosphere absolute for the different hyperbaric indications. And just to give you an idea, in relation to the depth of seawater, it's about 32 feet to 66 feet of seawater depth. Now, these chambers, either it's a monoplace or a multiplace chamber, whether it's made in the USA or other countries, it has passed a certain certifying agency. The Philippines don't have one, so we rely on the internationally recognized regulatory agencies. Now, talking about the Titan incident, according to the news, there was no certification done. That's why they don't really know if that 6-inch thickness of your carbon fiber will withstand the enormous amount of pressure of 4,000 meters. So it imploded. Now, for a hyperbaric chamber, the problem would be explosion. That's why it is very, very, very important that we have to get a chamber from a very reputable source with a very reputable certifying agency. Now, in relation to the treatments, this treatment should be prescribed and supervised by qualified physicians with appropriate training in this specialty. I'd like to mention about this mild hyperbaric oxygen therapy. You can see this in wellness spa, in health spas, and wellness centers, and the pressure inside is up to 1.5 atmosphere absolute. And usually this is not pressurized with oxygen. If it does, it's less than 95%. It is not FDA approved as a hyperbaric oxygen therapy, but it's FDA approved for acute mountain sickness. And you can see this in a wellness center. So other than carbon monoxide poisoning, the Southern Philippines Medical Center, Department of Emergency Medicine, and the Surgical Trauma and Critical Care usually encounters these types of indication in the emergency department. Arterial gas embolism, decompression sickness, severe carbon monoxide poisoning, CRAO, crash injury, compartment syndrome, acute thermal burns, neck fast, and gas gangrene. So they usually call us up, and we do emergency department evaluation of these patients. So other than the previously mentioned indication, the Undersea Hyperbaric Medical Society has other indications, and the total number of indications is actually 14 at the moment. All the rest of the indications are still off-label. Among the randomized controlled trial involving HBO and carbon monoxide poisoning, the group of Dr. Lynn Weaver in 2002, which involves around 300 patients for the duration of 7 years, which comprises the treatment session of initial 3 atmosphere depth followed by 2 atmosphere tailing dives within 24 hours. It seems to reduce the risk of cognitive sequelae 6 weeks and 12 months after acute carbon monoxide poisoning. So about 75% of hyperbaric patients did not develop neurologic sequelae versus close to 50% on the normal baric arm. Several neuropsychiatric testing were done along the course of the treatment as well as during the follow-up weeks and months. So carbon monoxide complicated with cyanide poisoning can be fatal. Hyperbaric oxygen therapy can also be an indication for this type of toxic gas poisoning. So now what are the evidences of hyperbaric oxygen therapy in other dyshemoglobinemia? For salt hemoglobin, it's more or less case series and case reports were reported, and seems like hyperbaric oxygen therapy has a role, especially those who are refractory to the standard treatment procedures. Also with the honestly, H seems like the results are again promising, but we need more structured studies in these indications. All right, I am now on the last few slides of my lecture, and I think the take-home message here is that hyperbaric oxygen therapy has a very important role in carbon monoxide poisoning, particularly the moderate and severe cases, in reducing the neurologic sequelae, as well as HBOT has a promising adjunctive role in the other dyshemoglobinemia. If you happen to have a hyperbaric facility in your hospital or in your community, you might want to pay them a visit and evaluate if they're able to help you out in this subset of patients. And also the recommended treatment protocol is the 3 atmosphere on the initial session, followed by a 2 atmosphere table within a 24 hours setting. All right, thanks again for having me and a chance to talk about hyperbaric oxygen therapy for carbon monoxide poisoning. As you can see, this picture depicts how busy we are at the moment. We are working in the emergency department residents. Thank you again and have a good day. Have a good day.
Thank you very much, Dr. Jeffrey Ramos, for that really, really in-depth lecture. Never knew that hyperbaric oxygen was such a powerful tool.
Actually, we encounter a lot of patients also in our institution who are divers, scuba divers. So this lecture is actually helpful for us in terms of managing these kinds of patients.
And now, and just a reminder that we need to answer our pre-test. The link will be posted in the chat right now.
After which, we now open the floor for our Q&A. Our speakers will be here with us, joining us again for the Q&A. So first, if we proceed, we have a question addressed to Mr. Rio Florido. How do you deal with patients presenting to the ED alone or with no companion able to communicate on their behalf?
Usually, patients, tox patients are being referred to us by the DEM. No? So it depends on the institution. So it's a case-to-case basis. So some institutions, they're still departmentalized. No? So for the pedia patients, it is being referred by the pediatrics. And then for the adult patients, it is being referred by the DEM. So usually what we do is, after receiving the referral from the patient, if the DEM deems necessary that the patient will be referred to the toxicology department, and then we will go to the patient, and then we will do um, the usual, no, to any other patient. So the ABCs of life support, no. So if the patient is a trauma patient, and if the ER thinks that the patient is intoxicated with alcohol, no. So you can do your DCAP BTLS or your trauma assessment together with your toxicology nursing assessment. So that's basically it. So in my experience, I've never experienced a patient coming alone without any relatives. Usually they're just intoxicated. But I've never experienced it. No, usually ano na sila, critical, no, or dinala ng rescue. No, so yun lang naman. So it is very important to note that, especially if the patient is a suspected patient, right after doing your ABCs of life support, take the CBG of the patient, no? Because, hypoglycemia can potentiate poisoning. So it is very important to take the CBG of the patient. So usually nakakalimutan kasi siya. Even if it's just a simple procedure, it is very imperative in your care for your poisoned patients. Thank you.
Thank you, sir. Actually, yeah, that's how we appreciate the institution that's capable of handling tox patients also, because there's a system in relaying the initial complaint of the patient for us to be able to aid in our history taking. Thank you,
Yeah.
sir.
Thank you, ma'am.
On our next question, we have a question from Dr. Christine Reyes. May I ask how to properly dispose poisonous chemicals at home? Directed at Dr. John Polner.
Yes, thank you for that question. Siguro yung binabanggit nung nag-question, yung poisonous chemical, maybe the household cleaning agents. Kasi dapat, di ba, wala naman tayong poisonous chemicals talaga sa loob ng bahay. And these chemicals, yung mga household cleaning agents, they are really not a threat if we use them properly. Okay? If we follow the instructions on how to use it, hindi dapat siya nagiging poison. Well, to handle these chemicals, ang kailangan lang talaga, you need to check the label, you read. Kasi sa lahat ng chemicals niyan, may nakasulat naman how to properly dispose. So generally, pagkatapos nyo gamitin, the container should be segregated. It should not be together with the general trash. And each local LGU, local government unit, has its own waste management agency. So maybe they could ask do sa kanilang LGU kasi its own protocols on handling this hazardous waste.
Thank you, Dr. Ner. So we have one more question, and this one is addressed to Dr. Ramos. May we ask, Doc, if what are the contraindications for your HBOT?
Thanks for the question, and thanks for having me for your very successful first day of presentation. The only absolute contraindication is actually untreated pneumothorax. Now, if your patient has pneumothorax and you're able to do CTT, then we can put the patient inside the chamber. But a multi-place hyperbaric chamber is suggested. Medyo mahirap sa monoplace. No? And there are other drugs, and most of these drugs are chemotherapeutic drugs that has not a very good combination with oxygen, with hyperbaric oxygen. Bleomycin, cisplatin, disulfiram, and doxorubicin. But as long as you will put this on hold for about 2 weeks, then you can put these patients inside. Now, for the relative contraindication, it depends on the capability and the, I would say, the status of the patient, how equipped you are and how experienced your facility could be. For example, for patients who has claustrophobia, that's quite a common experience, but we do put them on some anxiolytics just to continue with the treatment, especially if they really needed one. COPD can be a contraindication, and not all the facilities will put this patient because of the possible problem in pulmonary barotrauma. But again, if there is really a need, then there are procedures for that. Asthma is another relative contraindication, but as long as you medicate your patients, and we can put them inside a multi-place chamber. Pacemaker, implantable devices can also be a relative contraindication, but as you know, these implants in the subsequent years, most of these implantable devices are rated to 6 atmosphere absolute, and which our chambers are within those range. Pregnancy is another relative contraindication because they thought that there is a premature closure of PDA. If you have too much oxygen, you can have a premature closure of a PDA. But there was a big study in Russia, about 700 patients, and it seems like there is nothing that happened on that issue. Seizure is another one, but we can mitigate the risk of having seizure by doing a lot of air brakes. I think that's all that I can contribute for the absolute for the contraindications. And I just wanted to make a comment also that I have made an extra effort to introduce hyperbaric oxygen therapy because, again, it's a very new specialty in the Philippines, especially for the emergency department. No? And of course, there is a science into that more than the wellness thing and anti-aging. Making yourself beautiful. Now there is really a scientific and an indication back up with good evidences and studies from the international experts. And mind you, most of the researchers are actually coming from the emergency medicine specialty. Thank you again. Have a good day.
Thank you, Dr. Ramos. And we would like also to let you know that we appreciate your effort. Thank you so much for introducing that topic to us. Thank you so much, sir. Thank you to all our speakers again. Before we proceed with the awarding of our certificates, we would just like to remind our participants that the QR code earlier flashed in your screens for the earlier part of the program, as well as the link to the pretest that is posted in the chat. It's just one pretest. You just have to answer only one pretest for the whole day one course.
And once again, we are very grateful for the time our speakers have allotted in being able to join us today. So now, we are happy to present the certificates for our speakers. Okay. So, the St. Luke's Medical Center, Quezon City, Department of Emergency Medicine presents this certificate of appreciation to Mr. Michael Anthony Rio Florido for sharing his expertise during the virtual conference of our 28th postgraduate course entitled Ensemble, Concerted Efforts, Outstanding Outcomes, held on the 21st of July, 2023, via Zoom conference, undersigned by Dr. Rhea Guntalilib and postgraduate course director, and Dr. Arnel Torosa, department chair. We also present this certificate of appreciation to Dr. John Paul Nair, and the certificate of appreciation to Dr. Jeffrey Ramos.
Thank you so much for your time for our lecturers for this series. Thank you po.
Mga kababayan, ang pambansang awit ng Philippines.
Sorry for that technical difficulty. So I think we've had a productive morning so far. Um, and we all agree that the topics were quite stimulating, what with all the inputs from our lecturers. But I would just like to ask our participants, are you okay? No lateralizing weakness or numbness?
No slurring of speech, no sudden headache.
Wala tayong brain attack team dyan, okay? But I think we all agree that a break to stretch our legs and to refill our coffee is in order.
Yes, so let us have a breather for about 10 minutes or so, and let's listen to some messages from our sponsors.
Stroke recurrence is a real concern to worry about. Cognitive impact after stroke is marked. A few pharmacological studies have addressed vascular cognitive impact after stroke, and it was found that acetylcholine treatment improves temporal orientation and attention executive functions. In terms of long-term treatment, acetylcholine may improve post-vascular cognitive impact. In fact, treatment with milligram acetylcholine once daily or 500 milligram acetylcholine twice daily for 12 months in patients who suffer from reverse epilepsy stroke is proven to be safe. Choose those. Susubukan. Kami akan selalu Diagnosis can be an overwhelming experience for new patients and their families who face fear, anxiety, and uncertainty about their future. Research shows that 40% of patients with epilepsy respond to the first anti-seizure medication prescribed. That's why starting the right ENSEMBLE diagnosis is critical, as it can positively impact treatment compliance and overall outcomes in patients with epilepsy. But not all ENSEMBLEs are equal in safety and tolerability. Compared to the first generation ENSEMBLes, it brings a favorable balance of efficacy and tolerability. Here and now, more patients with focal epilepsy achieve better seizure control with better diagnosis outcomes. Is available to yet one is well tolerated in patients who utilizes both the first and ESMs, such as cardiovascular. That's why our first choice of ASM for all patients with epilepsy. Medication is simple and easy to administer in 2 weeks. It also offers the ease of interchangeability and bioregulation regardless of which patient is started. Is effective for patients with epilepsy.
Welcome back to our program. Hope everyone is refreshed as we get ready now to re-immerse into the second half of our course. But before we proceed, we have additional reminders. So we would just want to clarify. Earlier, we said that you just have to answer one pretest, so that's a given. At the end of the program, we'll be flashing another QR code for you to be able to answer or accomplish the post-test and the evaluation form. These forms are all required to be answered for you to be able to be given the certificate for this day one course.
We focus on something that we encounter and deal with daily, and because of its regularity, we often reduce it as a normal part of our jobs. I'm talking about pain.
Pain is actually the fifth vital sign. To quote a study done by Wakid et al. Last 2008, henceforth, the evaluation of pain became a requirement of proper patient care as important and basic as the assessment and management of temperature, blood pressure, respiratory rate, and heart rate.
That is right, partner. And which is why we present to you our third series entitled The Spectrum of Pain Management in the Emergency Department. Starting with our first speaker, Ms. Maricar Bernal, or Ma'am Fuji as she is most known, just recently received the Nurse Leader Award from St. Luke's QC and has been a consistent source of guidance to the junior staff in her role as an emergency care nurse. As someone who is exposed to the acutely ill, may it be at the initial triage or at bedside, she has honed the critical eye and immediate assessment of someone in discomfort. To share with us her tools, tips, and tricks of the trade, let us welcome Ms. Maricar Bernal.
Good morning. Thank you. for attending this annual 28th annual postgraduate course of the Department of Emergency Medicine, Philippines Medical Center, Quezon City. I am Maricar Bernal. I'm one of the emergency care service nurses of Philippines Medical Center, Quezon City. And today I was tasked to discuss about the nurse-initiated pain assessment and tools. So our topic, the nurse-initiated pain assessment tools and tips. So our objectives for this lecture, to be able to define what is pain, to differentiate between types of pain, to identify and distinguish the appropriate use of pain assessment tools, and to determine the different approaches on how to assess pain. So what are our basic pain assessments? So in our everyday life in the ED, we always see numerous patients or they come to us in the ED with chief complaints of pain. So some of our patients are discharged, but some are also admitted due to persistence of pain. So where do we begin? Pain is considered as the fifth vital sign. So as what we always say, pain is subjective and highly individualized. So its stimulus is either physical or mental in nature, and only the patient knows whether pain is present and how the experience really feels. So per J. Caho, 2000, Joint Commission on Accreditation of Healthcare Organization introduced standards for pain assessment and management relevant to multiple healthcare disciplines and settings. So these standards stress patients' rights to appropriate assessment and management of pain, and emphasize that pain should be assessed in all patients. So as nurses, why do we have to assess pain? So the most common reason for unrelieved pain is the failure of staff to routinely assess pain and pain relief. So if we do not assess the intensity of pain of our patients, so we are not helping them to alleviate or at least lessen the pain that they are experiencing. So what is pain? So it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So it is described by the International Association for the Study of Pain. So we have our classification of pain by origin and by time frame. So by origin, we have our nociceptive pain, which includes the somatic and the visceral pain, and the neuropathic pain. So for the time frame, the patient has either acute or chronic pain. Now for your nociceptive pain, so we have your somatic and your visceral. Your somatic pain, which is well localized, sharp, pricking. Samples are your burns, cuts, and concussions. So your visceral pain, they are poorly localized, colicky, and vague. So intra-autonomic reflexes, your nausea and vomiting, hypotension, bradycardia, samples of which are your tumors, appendicitis, and pancreatitis. So your somatic pain is originating from the skin, muscles, bones, or connective tissues. Or your visceral pain has pain test results from the activation of nociceptors of the thoracic and your abdominal viscera, such as your cramping, throbbing, pressing, aching pain. So examples are your labor pain or your angina pectoris. So these are your somatic pain and your visceral pain. So for your neuropathic pain, it is a pain caused by a lesion or disease of the somatosensory nervous system. So these are the examples of your neuropathic pain. So the classification of pain by duration is either acute or chronic. When we say acute, it has a protective or biologic function. The patient may feel tachycardic, hypertensive, and tachypneic, meaning until the injury has healed. It is associated with anxiety, often within 3 months duration, and responsive to usual analgesics. While your chronic pain, it has no protective or biologic function, may not manifest at all. Patient may not have tachycardia, increased respiratory rate, or hypertension. It persists long after the injury has healed. It is associated with frustration. It may last beyond 3 months up to several years, and it requires adjuvant analgesics. So this is your acute pain and your chronic pain. So as nurses, we use different assessment tools. So what are those different assessment tools? We can use the unidimensional scale. They are your visual analog scale, your numerical rating scale, your verbal descriptor scale, and your faces pain scale. So your visual analog scale, it is a horizontal or vertical line with words that convey no pain and worst possible pain. So the patient is asked to place a line that indicates his or her level of pain. So that is your visual analog scale. And then your 0 to 10 numerical ratings. This is the commonly used rating scale in the ED. So your pain score 0 to 10, 0 as no pain, and 10 is the worst possible pain. And then 5 is your moderate pain. So we ask the patient what is the intensity of their pain scale. And then your verbal descriptor scale. So scale, you have your 0 to 10, 0 as no pain, and 7 to 10 as severe. 0 to 10 as well, 0 as no hurts a little bit, 4 hurts a little more, 6 hurts even more, 8 hurts a whole lot, and 10 is it hurts worse. So they are your unidimensional pain assessment skills. Now we also have our multidimensional pain assessment tools. So your pain assessment tools for pediatric patients. So we all know that it is very hard to assess the pain scale or pain intensity of pediatric patients. So this somehow may help us in assessing their pain. So you have your pain assessment tools for pediatric patients, your premature infant pain profile, or your PIP for premature babies, your neonatal or infant pain scale for children less than 1 year old, or your NIPS, and your FLAC behavioral pain assessment scale may be used for children 1 month to 3 years. So for your PIP, we have here your chart, you have your process, your indicators, and the corresponding scores. So based on your assessment, you will have to score them and total the score. So the PIP score equivalent are 0 as no pain, 1 to 6 mild pain, 7 to 12 moderate pain, and 13 to 21 is severe pain. So you just have to choose on those descriptions where is the score of the patient. Then your neonatal infant pain scale or your NIP. So your pain assessment, and it has a corresponding score as well. So it includes your facial expression, your cry, breathing pattern, the legs, and the state of arousal. So for your score, a score of more than 3 indicates pain. So that's for your neonatal or your infant pain. Now for your FLAC, so your FLAC stands for face, legs, activity, cry, and consolability. So your scoring also is 0, 1, and 2, and then you have to get your final score. So 0 has no particular expression or smile, no legs, no position or relaxed, activity, lying quietly, normal position, cry, no crying, consolability, content, and relax. So basically that's 0 score. So for this one, it has a total score of 5 out of 10. So interpreting the behavioral score, 0, relaxed and comfortable. 1 to 3 is mild discomfort. Your 4 to 6 is moderate pain. And your 7 to 10 is severe discomfort or pain for both. Then we also have your pain rating scale for critical care patients. So critical care pain observation tool. So what are your indicators? Your facial expression, your body movement, your muscle tension, compliance with ventilator, or vocalization. So our patients will be ventilated. So 0, 1, and 2 are the corresponding scores. Again, we have to get the total score. So 0 is no pain, 1 to 2 over 8 is mild, 3 to 4 over 8 is moderate, and 5 to 8 over 8 is severe pain. And we also have our pain assessment in advanced dementia scale. So our indicators, your behavior, breathing, independent of vocalization, negative vocalization, facial expression, body language, and consolability. So again, they have their corresponding scores based on your observation and assessment. And again, we have to get our total score. So mild pain is 1 to 3, your moderate pain is 4 to 6, and your severe pain is 7 to 10. So for elderly patients, so we use this for elderly patients. So as nurses, how do we assess pain of our patients? So we have our WILDA approach. So WILDA stands for words to describe pain, I for intensity, L is for location, D is for duration, and A is the alleviating and the aggravating factors. So the words to describe pain can be aching, tender, penetrating, stabbing, dull, deep, radiating, burning. So a universal adoption of a 0 to 10 scale, with 0 being no pain and 10 being the worst pain imaginable. So this is your I for your intensity. So ask the patient to rate the present pain, the pain after the intervention, and the pain over the past 24 hours. So usually our patients stay in the ED for not so long. So the pain reassessment over the past 24 hours will be done in the units for admitted patients. And then your location. So we have to ask our patients, where is the pain? Do you have pain in more than one area? Is it unilateral or bilateral? does it radiate to other areas as well? And do the area differ under different circumstances? So ask the individual to point site of discomfort. For your duration, is your pain always there? So we have to ask the patient, does your pain come and go? Or how long does the pain last? Now for the aggravating and alleviating factors, what makes the pain better or worse? How does pain affect your sleep, your appetite, energy, activity, relationships, or mood? So are you experiencing nausea, vomiting, constipation, itching, sleepiness or confusion, urinary retention, or weakness? So those are your aggravating and your alleviating factors. Now another one that we use is our PQRST approach. Your P provoke, what makes it better or worse, quality for burning, shooting, radiation, and then the severity and timing. We have also your old cards approach. So it stands for onset, location, duration, character, aggravating, alleviating, radiating, timing, and severity. So most of our approaches have the same or common factors that we ask. So it is there. Quality, the severity, the timing, the radiation, and the location. So the best assessment tool in the world don't work if we don't use it. So it is always important for us nurses that we always do our assessment and reassessment when it comes to pain of our patients, because we will not be able to help them lessen the pain if we do not reassess our interventions that have been done. So when we give medications like oral medications, we have to reassess the pain scale of our patients in an hour. And for our IV medications, we have to reassess the pain scale of our patients after 20 to 30 minutes. Now, as nurses, we also have to document the interventions that we have done, and also we have to document in the patient's chart if there is any change in pain scale. And we always have to continue to collaborate with our doctors for better treatment of our patients. So our measure of success, you're living pain, enjoy the journey. So our references, American Pain Society, Geriatric Pain, NCBI, and your WebMed Pain Management. Here are for the rest of the lectures. Thank you.
Thank you very much, Ms. Bernal, or Ma'am Fuji, as she is popularly known here. Difficulties you encountered with regard to the background of that previous lecture.
And now we move on to our lecture. In our second lecture, in the spectrum of pain, our next speaker is a current EM consultant here at St. Luke's and the research coordinator of the Emergency Medicine Department. He is also an assistant professor of St. Luke's College of Medicine and has a master's in health professions education. And being a founding member of the Philippine International Cannabis Association for Research and Development, are forgive my time. Hi. Let us all welcome Dr. Peter Kilala.
We apologize. Dr. Kilala is just setting up his video for the. So we've had actually a productive next series for our pain series lecture. Partner, because I think is quite intriguing. Actually, in terms of the pain assessment, I think there's it's like a whole new perspective for us doctors as
May I
well
ask for
because
acknowledgement if you can see my slide?
yes, doc, we can see it clearly.
Thank you. Thank you, Gino,
Hello, doc.
Dr. Gino, and Dr. K for that very generous introduction. And let me ask the audience if they are still awake because you will experience a little high from my lecture. Not much high as Dr. Gino is expecting.
We're all ready, doc.
All right. Thank you very much. So my task for this morning is to on evidences, some anecdotes of this plant in the emergency department. So these are my affiliations. I have a very important disclosure. So I am a current advocate in the current legislation for the medical use of cannabis. I have conducted university research on medical cannabis via the Compassionate Special Permit. And I'm a current member of the Philippine Society of Cannabinoid Medicine, a SEC-registered medical society, and have campaigned for accreditation of a medical cannabis party list. A disclaimer for this session is that the session will provide information on the potential medicinal use of cannabinoids and the plant cannabis for the most common complaint of patients seeking consult in the emergency department, and must not be construed as providing medical advice and training to use any product of cannabis currently in the Philippines. So I've set the following outcomes based on those objectives given to me. So by the end of this session, the participants shall acquire knowledge on the known pharmacologic actions of medical cannabis specifically for pain, have an awareness of current legislation on medical cannabis and its accepted indications, including pain. For the participant to be critical of available literature, as well as available practice guidelines from reputable countries conducting research on medical cannabis for pain. They shall have an understanding and knowledge of the potential of medical cannabis for clinical use in the emergency department. So this is the endocannabinoid system, a system which is not really familiar to most healthcare providers. So just like your autonomic nervous system or any other systems in the body, it has been known, and the processes involved in pain mediation and modulation has basis in its cellular and molecular basis. The first circle or the connector one, and that like in body, we keep regard these receptors and their mediators for their physiologic or pathologic effects. So you see here the presynaptic receptor, the presynaptic cell or the neuron, which contains the CB1 receptor, and you have the endocannabinoid mediators, and one of which is called the anandamide. Anandamide is native to our body, has been discovered for a long time, and it is derived from the Hindu term ananda, which means bliss or happiness. Hence, the primary effect of this plant. So we cannot consider cannabis with its lone active mediator, which is your cannabidiol. You know that the cannabis plant, the most active of which is the female flowers, which is covered with trichomes. And this part of the plant contains most of its active properties. And they produce the following cannabinoids, terpenes, flavonoids, sterols, and other molecules, which can mediate for a lot of its physiologic effects. And these molecules does not stop there, because there are more than 500 different molecules which helps in the medicinal effect of your cannabis. These molecules fulfill a range of functions, one of which for its own protection by repelling pests. It is very ubiquitous because it does not fall prey to herbivores, microbes, fungi, and even the sun. So when is the timeline of medical cannabis from its medical use until the time it became a molecule or a plant that has been placed in the darkness of healthcare? So in ancient times, the Egyptians used cannabis, and during this time, it is already in their treatises that has been used for treatment of illnesses even during those times. In about 1964, a flashback, okay, tetrahydrocannabinol, that molecule has been discovered. So before the active principle, THC was discovered by a Israeli chemist by the name of Raphael Mechalom. And in 1996, California, the first state, legalized its use for medicinal purposes. However, it was outlawed in 1937 because of the influx of this plant coming from neighboring nations, which the influence of its of being outlawed is because of its entry and its prolific cannabis, whether for recreational and for medicinal purposes. And before the pandemic, it was already announced that cannabis is no longer part of Schedule 1, a schedule which it means that it is a dangerous drug, and it is no longer, since they reclassified cannabis and recognized their therapeutic uses. When I say their therapeutic uses, because of the several strains available from around the world, whether they are in Europe, in the Middle East, or even in Asia. We have our own cultivars. However, they are not yet classified as with therapeutic uses. They are still classified as dangerous drugs. Most common cultivar illegal of this presence of the plant implemented prohibition and has been the medical use has been outshadowed, and that the racially motivated import of Mexican and African American into its are to be found due to political energy, which means it was due to police made easy opposition from alcohol, pharmaceutical, corporate interests of the myriad of beneficial medical effects that this plant entails, sense of moral and ethical protection to society. Is here on misplaced sense. Most of the discussion on cannabis such a long time was effects, and a lot of the studies are that it minimally produces. The actual and perceived harm that this produces are already documented. However, are they significant enough that the benefits of this plant would be outshadowed? So there's still a stigma on the legacy of the use of cannabis, but currently it is slowly being diminished because of increased countries, namely the most recent one is Canada. The one with most researches would be Israel, and those with practice guidelines similar to the medicine that is being done here in the Philippines, in Australia. And slowly but surely, and now exponentially, the interactions between many more of the molecules that are discovered from this plant, humans are being studied with great attention. So these are the current molecules that you can find from the plant, and those that are derived from the plant, which are synthetically produced. And of course, those that are found native to our body, which are the endocannabinoids. So you will see here the same receptors and the same second messengers or cytosolic messengers that these molecules interact with. So these receptors on which cannabinoids act produce intracellular effects, three of which would be inhibition of neurotransmitter release or prevention of some of the non-neurotransmitters that can cause pathologic effects, one of which would be your adrenergic mediators. They modulate gene expression. This is very important in its current novel use, which is an anti-cancer effect. Pain transmission modulation is our current topic at hand. Nervous system, which is the target
Meant for disorders like anxiety, ADHD, and autism, or is medical cannabis only used for pain? So may we have first Dr. Kilala?
Okay, thank you for that question. Of course, my topic is for pain, but there is a guideline on the use of cannabinoids for patients with autism. However, it is not as large as those being used for pain and other indications. So there are practice guidelines being used now by the Australians for the use of cannabinoids for autism and ADHD. Because I really cannot cite something here from the Philippines because there's none.
Thank you, Doc. May we have then Dr. Basco Tiamson for the same question? Thank you, Dr.
For the real indications of medical cannabis, we only have two proven for treatment-resistant seizure disorders, and that's Lennox-Gastaut and Dravet syndrome. But for pain, actually, there's no indication now for the use of there are some patients but it's all under the table, di ba? And let's if I may just say, the International Association for the Study of Pain still does not advocate the use of medical cannabis for it's not a closed book, no, it's open to more research kasi as of now there's no robust study talaga supporting the use of medical cannabis for pains. World peace, world
Thank you,
peace
Dr.
tayo.
Thank you, Doc. Actually, that's one of the purposes of our postgraduate courses, to be able to present a series of lectures that will open up other topics, in terms of the broad spectrum of the coverage of other uses or utilization of your, just what we're having right now, of your medical cannabis. So we're given different perspectives or views.
If I might just say, in a recent ASEAN Pain Congress that we attended in Thailand, when we were talking about lived experiences of their pain doctors as to medical cannabis use for pain and palliative care, the benefit that they saw with regard to medical cannabis use is not actually for pain, but more of improvement of appetite. No? So if you're able to make your patients eat at the end of life, so they find value for the use of medical cannabis. Pero for pain, di pa talaga. More of opioids pa rin talaga sila.
Thank you for that input, Dr.
Now, moving on to our last question for now. One addressed to Ma'am Fuji. In your opinion, given that nurses are usually the one who see a patient first, if a patient is in severe pain and the doctor for some reason is not present at the moment, is it okay for them to give medication prior to informing the doctor?
Thank you, Doc, for that question. Well, in my best opinion, or should I say my most legal answer, so it is true that we nurses usually see our patients first from the triage, and given our nursing abilities and skills to assess our patients, we should always remember the scope of our nursing practice. So the best way to address it is to refer immediately to our doctors and then immediately give the ordered medication. So we always have to the valid decision. Thank you.
That is a very fair and very legal answer. Thank you very much, Ma'am Fuji.
Again, we would like to thank our panelists, our lecture for this series. Thank you so much, Ma'am Fuji. Thank you, Dr. Kilala. Thank you, Dr. Basco. I really appreciate this opening up and discussing this topic for us. So now, if we may, we would want to do the honors again to present our certificates to speakers. So this certificate of appreciation is proudly presented to Ms. Maricar Bernal for sharing her expertise during the virtual conference of our 28th postgraduate course entitled Ensemble, Concerted Efforts Outstanding Outcomes, held on the 21st of July 2023 via Zoom conference, undersigned by Dr. Rhea L. Guntalilib, Postgraduate Course Director, and Dr. Arnel Tolosa, Department Chair. The Certificate of Appreciation is also presented to Dr. Peter Kilala and to Dr. Maria Elena Basco Tiamson. Thank you so much, doctors, and thank you, Ma'am Fuji, for your time. So before we proceed with the next part of our lecture series, we would like to remind everyone to answer the pre-test. The link is provided in the chat box. And then later again, we would be showing a QR code and we will be posting the link as well to the evaluation form and to the post test. Again, a reminder, you are required to accomplish both the pre-test, the post-test, and the evaluation form for you to be issued the e-certificates. And also, we have a bonus for them. So upon filling up all those forms, including the evaluation form and the post-test, we will be having a raffle. So would you like to discuss, partner, how they will be chosen? They will be chosen via random numbers. So unfortunately, due to the interest of time, we will not be able to announce the particular winners, but the department would be personally sending you either a text message or an email to make you, to relate to you that you're one of the winners of the raffle.
And now, moving on to the second to the last portion of our lecture series. So these have been very interesting and fascinating lectures, but we are sure that our second to last series will also pique your interest just the same. In lieu of celebrating the 20th anniversary of the section of Pediatric Emergency Medicine in SLMCQC, we present to you a special lecture series dedicated to the pediatric population.
Even though the COVID global emergency has been declared by the World Health Organization as over, there is still yet another pandemic that's been lurking among us.
Akin to how ischemic heart disease is the leading cause of illness among adults, mental health disorders such as depression, anxiety, and behavioral disorders are actually the leading cause of illness and disability among teenagers.
Due to the conflict in the schedule, we will be first having our first lecture will be Dr. Rifarial. Please do the honors, partner.
All right. And if you're in the field of psychiatry, our next speaker's name will certainly ring a bell. Dr. Perez Rifarial had her residency training in psychiatry at UPPGH and has gone international to Singapore, where she obtained her fellowship training in consultation liaison psychiatry. She has been a strong advocate of mental health and had multiple speaking engagements on multimedia platforms. She is currently the Residency Training Officer of the Department of Psychiatry at the Veterans Memorial Medical Center and has been elected this year as the Board Secretary of the Philippine Psychiatric Association. It is our pleasure to introduce to you Dr. Joan May Perez Refarial.
Hello, good morning to everyone. Thank you very much, Dr. K, Dr. Gino, for your very kind introduction. Thank you very much, Dr. Ray Torres. Really, I am so thankful and grateful for the daily reminders or constant reminders about my lecture for today to the organizing committee of the postgraduate course of St. Luke's Medical Center, QC, Department of Emergency Medicine. Maraming salamat po for inviting me, and to everyone here today, good morning to everyone. And the previous speaker, in fact, is a very good friend, my batchmate from med school. Hello, Dr. Tiamzon. All right, so allow me please to share my screen. And really, I'm so grateful. In fact, just to share, before I share my screen, my husband I'm sorry, my husband, I'm so sorry. Hello? Binawala ako, B. Hello? Hello? Hello?
Yes, Doctora.
I can't hear. Oh my God, I can't hear anything.
We can hear you, Doc. Hello, Doctora.
Hello?
Can you hear us po?
Hello? Oh no.
Yes, Doc.
Parang mahina. All right, Dr. Ray. Oo, talagang background lang, no? My husband is also an emergency medicine specialist, and I'm currently here in Baguio, and that's why siguro from time to time the Wi-Fi is a bit spotty. So this is my outline for today's discussion. So first, I will give a brief intro about mental health, which is something very close to my heart, and stress and its relationship. We will see later on how this is related to anxiety and depression among the teens. So youth mental health concerns pre and during pandemic. And lastly, we look into the holistic approach. We call it the biopsychosocial approach in the management of anxiety and depression. All right, so let's start with mental health and stress. Have you heard of this line from the World Health Organization, which states that there is no health without mental health? Oh, do you agree with this? Diba? Yeah, no? Kasi according to the World Health Organization, health is defined as a state of complete, it's in fact complete, no? Physical, mental, and social well-being, and not merely the absence of disease or infirmity. And that's why mental health is equally important as physical and social health and well-being. Now, zooming in on mental health, it has 4 elements, 4 dimensions. So you can read from the slide, no, when we say mental health, what is it about? So it's about knowing our ability, our talents, our skills. So, diba? As ER medicine specialists, you know what your skills are. Talagang you are highly trained. You have a very specialized skill set. You know how to cope with the normal stressors of life. That's the second dimension. Third, mental health also means that we are able to work productively and fruitfully at the end of each day. And lastly, we are able to make a contribution to our community, especially to your community here in St. Luke's Medical Center, and of course, to the whole country and worldwide. So I would like to highlight lang 2 very important words here in the definition of mental health, which are related to our topic for this morning. And these words are stress, number 1, and cope, our ability to cope or handle our stressors well. Do you know that stress is a part of life? Kaya nga, that's why it's here in the definition of mental health. It's clearly stated here that stress is there, and there is in fact a good or positive form of stress, now, which is highlighted here in the yellow portion of the curve. So a bit of stress, a bit of stress, in fact, is good. It says here optimum stress. It can push us to get up in the morning, wake up, come to work, come to duty on time, and not be late for work. So, which means that a bit of stress can help with our productivity, but take care that we do not fall into the green part of the curve, which is the part wherein a person is too laid back, too relaxed, diba? Sobrang chill, and that's not also good. And of course, let's also avoid the other extreme, the orange or the red part, which is stress or distress because of stress which was not managed or handled well at the onset. Who do you think is the age group which would have the most stress? Would it be the children, the teens, the adolescents, the adults, the elderly? A study from the American Psychological Association showed that the millennials, who are the millennials here in this group? Currently, they belong to the age range of 26 to 41 years old, and the Gen Xers, which would include myself, 42 to 57 years old would suffer the highest levels of stress, which is understandable because these age groups would have the most number of sources of stress, possible sources of stress. Speaking of sources of stress, what are the top 10 causes of stress? What do you think is the number one cause of stress? But sige la, I'll show you the top 10 immediately. Kaagad na. Oh. Money, in fact, is number one in the list. But I just highlighted here because in relation to our topic on teens and adolescents, school is a potential stressor. It doesn't mean na Gen X the population who would experience stress would be the Gen Xers and the millennials. Of course, everyone, diba, can have or experience stress, but and we can see from here that school can be a stressor. And what about school? What about school? Na? So what are the most commonly reported stressors in the academic environment? So from a study published in 2008, according to students, it's about oral presentations. O diba? Speaking in front of a class. Na? Kasi there is that feeling or apprehension, fear of being judged, fear of stuttering, saying the wrong things, academic overload, lack of time to meet various commitments, be it extracurricular activities, co-curricular activities, and taking examinations. I'm sure we can relate to this because at one point in our lives, we have encountered this source of stress, which is related to academics. So again, please, as mentioned earlier, there are the top 10 sources of stress were there. But of course, there are other potential sources of stress, but make sure that we are able to identify. That is, in fact, very crucial. Identify your sources of stress, the triggers, so that we can manage our stressors well and avoid, again, I would like to highlight, avoid this part of the graph, of the curve, which is prolonged stress. Too much of stress, which may lead to symptoms of anxiety, panic attacks, irritability, anger, or mental breakdown. For those in the workplaces, like healthcare professionals like us, it may lead to burnout, symptoms of burnout. So again, make sure that you acknowledge and you are aware of the sources of your stress so that it does not complicate into becoming anxiety or depression in the long term. So now let's go back to our focus, which is on the younger age group, the youth. Let's look at their mental health concerns pre and during pandemic. Do you know that the teenagers currently, they are called the Gen Zs, di ba? Gen Zs. Kasi kanina nga, millennials and the Gen Xers would have the most, the highest form of stress. The severity of stress is higher for them. But let's look at Gen Zs. Here is a study published recently in 2019, pre-pandemic. The title of this study is Gen Z are more likely to report mental health concerns, and it was published by the American Psychological Association, Stress in America survey. This focused on Americans from between the ages of 15 to 21. Now let's take a look at Gen Zs. This is the generation now who belong to this age group, age 7 to 21, more or less. Kasi generations naman, it's not naman talagang definite. It's more or less an estimate of their age range. So more or less, they are the individuals now in their late elementary and high school and early adolescence and early adulthood. All right. So more or less age 7 to 21. And the study showed that this generation, these Gen Zs now maybe kasi you have siblings who are Gen Zs, you have children, kids who belong to this age group. This report showed that this generation tend to report their mental health, their state of mental health as fair or poor. So talaga they're open. This generation now, they are open to talking about their mental health concerns, and 37% report that they have received treatment or therapy from a mental health professional, which means that this 37% personally for me, this is good, diba? Good in the sense that there is that awareness now about mental health concerns, how it affects one's overall health, well-being, functionality, ability to be productive in school, and be better members of the society. So again, from this study, the high percentage of Gen Z reported that having poor or fair mental health means that it's an indicator that they are more aware and are accepting of mental health issues. Now let's take a look. What differentiates Gen Zs from us? Oh, from us, from for example, na lang, no, from me as a Gen Xer or from the millennials. Ang generation is shaped by three factors. No, one is parenting styles, another is technology, and the third is economy of that generation. Let's focus now on this. It's a it's very this is something now that we usually see, social media. So there is in fact a link between Gen Zs and their use of social media, and we will see later on the concerns from excessive use. I use the word excessive use of gadgets or social media. The Gen Zs are called the digital natives because they grew up surrounded by digital information and entertainment on screens, and screen time is a major part of their lives. Diba? Do you agree with that? Talagang, yes, it's a part of their generation, and we cannot fault them. We cannot blame them for that. It's really part of their generation now, the Gen Zs, but please take note that social media may be affecting one's mental health because some studies have shown that it can be addictive. It triggers more sadness because there's the tendency to compare our lives with what we see, we read from other friends' feeds online. Excessive use can lead to jealousy. There is that illusion of Facebook bringing happiness, the more friends, but we know that these are all highlights and not really, it can be filtered, edited versions of ourselves, and that's why we need to be aware of the potential risks for excessive use of social media. Having more friends on Facebook does not mean being more social. In fact, it's the opposite. Sometimes we feel isolated on our own, and we see Facebook or social media as a form of connecting with virtual friends. Now, friends who we haven't seen for a long time, or friends really unknown to us. And there is such a thing called social media envy, and which was shown to be a moderate, significant predictor of symptoms of depression among Filipino high school students. This was a study, again, published or released in 2017. One of the dangers of social media, and protect your kids, your siblings, or friends who belong to the Gen Z, would be cyberbullying, which can also add to symptoms of anxiety and depression. Cyberbullying, we know any form of bullying can have tremendous impact on one's self-esteem and may cause some concerns related to mental health. These would include sending mean texts or instant messages, pranking, hacking, being rude or mean. So take care if you have younger kids, siblings. Sometimes we are not sure what they're doing online, and they may receive mga mean messages, rude messages, which can be demeaning, diba? Or embarrassing or humiliating, and can really have an impact on how they see or perceive themselves as individuals. Spreading secrets or rumors about people online, or pretending to be someone else to spread hurtful messages online. But again, we cannot separate this generation from gadgets and social media, being the digital natives that they are. So what's important is to really to help them find the balance, that they have control over their use of gadgets and social media, and not the other way around, not to let social media and gadget use take control over them. looking at the Philippine context now, because the study presented earlier was based from a review of literature from the US, diba? From the American population. So let's look at the Philippine context. Do you believe that Filipinos are really one of the happiest people in the world? Is this true? Studies, in fact, have shown pre-pandemic that 1 in 5 Filipinos would have some form of mental health disorders, and majority of this would be those who would have depressive disorders or depression, followed closely by anxiety, which are our topic, the mental health disorders, which are part of our topic for this morning. So yeah, so 3.3 million Filipinos during the time had symptoms of depression, followed by 3.1 million Filipinos with anxiety disorders. But take a look at high school, the number for the younger generations, the teens, high school students, according to the Global School-Based Student Health Survey, done again pre-pandemic. The conclusion from this study showed that Filipinos have shown increased prevalence of mental health conditions or problems, with an alarming increasing trend of suicide among the youth. Again, this is very alarming, and that's why I'm really happy that the Department of Emergency Medicine included this topic today to raise awareness about depression, anxiety, and suicide. Looking at it from looking at the factors which may lead to one being more at risk or predisposed to having these mental health conditions, there is always an interplay. It's always an interplay. We cannot pinpoint or single out just one trigger or one factor. It's always an interplay of all of these variables, be it biological factors, which includes genetics, brain chemistry, the brain chemicals in our brain, we always call it yung mga hormonal imbalance, quote unquote, life experiences like trauma, traumatic events, abuse, and others, which was mentioned in the top 10 list of stressors earlier during the lecture, and availability of social support. Again, social support, availability of a solid support system for us is very important. Now let's take a look at the biological factors, brain chemistry. Sorry. We know that there is depression, in fact, and anxiety are closely linked because they share the same neurotransmitters responsible for the dip in the mood or for the emergence of anxiety, mga panic attack symptoms. And these hormones or neurotransmitters in the brain would include norepinephrine or adrenaline, diba? Yung epinephrine also, or adrenaline rush, diba? That's why we feel the panic attacks, because of the adrenaline rush. Dopamine and serotonin. So they share the same neurotransmitters in the brain. And thus, again, there is also a huge overlap in terms of the symptomatology. They may share some common symptoms. That's why in the clinics, when we see someone with symptoms of depression presented here in the red part of the diagram, we also screen na rin alongside symptoms for anxiety because of the huge overlap. And please remember that when we say depression, there's extreme, intense sadness, feeling of worthlessness, helplessness, to the point that they feel so hopeless. They feel that life is meaningless, and there's lack of energy, low motivation, lack of interest, changes in sleep and eating there can be sleep and eating pattern changes. And for anxiety naman, it's more of the panic attacks, anxiety symptoms, palpitations, etc. And common to these two disorders would include cognitive symptoms. That's why sometimes cognitively they're unable to concentrate, focus, kasi there's a lot going on in their head, excessive worrying and agitation. Please know that when we say mental health concerns or mental health disorders, there is always distress. Yun lang yun. Kasi it's normal to feel sad. It's normal to feel anxious, but there's that component of distress. Nadi-distress sila to the point that it interferes already with their academic performance. It affects their work. It affects their relationships because they can feel irritable, leading to problems with relationships. In kids and teens, it may present differently. They may show irritability, laging galit, bugnutin, anger, behavioral problems, cutting school, cutting class, truancy, drug use, sexual promiscuity, again, problems with ACADS because of difficulty concentration, preoccupation with morbid themes, heightened expression of boredom, and frequent body aches and pains. Usually, it's body aches and pains which is unexplainable. Today, they may miss class, for example, because of headache. Tomorrow, it's masakit ang tiyan, masakit ang tuhod, masakit ang likod, masakit ang batok, masakit ang kasukasuan. So it's pain, which is really unexplainable by a medical problem. Similar to anxiety, again, it's normal to feel anxious sometimes. Again, diba, there's that normal feeling, but when it's very excessive, intense, to the point that it affects our functionality, productivity, it affects our relationship, self-care even, then that becomes quote unquote problematic already or abnormal. Usually patients come to you in the emergency room presenting with this, diba? For emergency medicine physicians, you will see patients presenting with this. And the usual chief complaint is, mabilis po, Doc, ang tibok ng aking puso, mabigat ang dibdib, para bang mabilis ang takbo, no? Mabigat ang dibdib, palpitations, high BP, there's tremor, shaking, difficulty breathing, and that's why they come to the emergency room. But before we say that it's really an anxiety attack or an anxiety disorder, please make sure to rule out all possible medical problems, which may also present with symptoms of anxiety as shown in this slide. During pandemic, we know that we've been affected by the pandemic, all of us, more so with the young, with the youth. In a research study between January to October of 2020, an average of 44, grabe no, suicides a month were reported, and out of the 40 deaths, 58% of these persons were under 30. Again, this is really alarming, and that's why we need you, ER medicine specialists, to really be more vigilant about the screening for suicide amongst your patients who go to the emergency room with mental health concerns. In the new normal, again, the youth are facing challenges now with regards to transitions. Diba, when we go through transitions in life, be it a new workplace, new school, we go through a roller coaster of emotions. There can be academic pressure from the family to perform well, lalo na with the transition now from face-to-face, from online to face-to-face, or face-to-face to online, hybrid. Transitions pa rin. These are all considered transitions, and for students, these transitions may make them feel that they're not able to, it's out of their control. They have no control over these situations, circumstances now, and it may lead them to feeling overwhelmed. In fact, with the transitions now, the Department of Health, NCMH, in 2022 reported a surge in calls. From January to September of last year, they received 14,200 calls, and majority of the callers were below 29 years of age, or those belonging to the millennials and Gen Z. And that's why we really need to help these age group, the young, the youth. So lastly, how do we help them? Let's help them, all right? So we follow the biopsychosocial approach in the management of depression and anxiety. You may download this. This is a very helpful screening tool called the HADS, Hospital Anxiety and Depression Scale. It's a self-reporting questionnaire. So the patients, the youth, the teens will answer it. There's just 7 questions for anxiety, 7 questions for depression. It was found to perform very well in assessing symptom severity and caseness. Na talaga, it will pick up symptoms of anxiety disorders and depression. So this is how it looks like, and the patient will just tick, 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 and then you will look at the scoring there. So, and then you can see, oh, talagang mataas, no? The severity of symptoms is quite high, and maybe there's really a need to maybe refer to a psychiatrist or suggest admission to the hospital for proper assessment and monitoring. Another, as mentioned earlier, they may present with body aches and pains, which is unexplainable by another medical problem. So we can also ask them to answer this. It's a somatic symptom scale, which looks at different symptoms of anxiety and depression. So following the biopsychosocial approach in the management of anxiety, depression, biologically addressing the serotonin, this yung diba I presented kanina, no? The neurotransmitters involved, usually for the pediatric age group, we give SSRIs, the selective serotonin reuptake inhibitors, SSRIs, specifically sertraline, escitalopram, or fluoxetine. And for anxiety, we give anxiolytics like benzodiazepines, particularly alprazolam. Again, we start low, go slow, especially for the pediatric age group. We also do supportive psychotherapy, quote unquote, talk therapy. Now, usually CBT, we listen to them, talk to them. Please make sure that in the emergency room, baka lang kasi someone comes in presenting with symptoms of anxiety and depression. What not to say, doctors? Not to say, ha? Do not say this. Wala yan. That's just a phase. You'll snap out of it. You're so selfish. You're just trying to get attention here. Get over it. Please never say this. All of the symptoms, emotions of our teens, the young adults are valid. Depressed? Excuse mo lang yan kasi tamad kang pumasok sa school. Please avoid this. Never say this. Hinga ka lang. You'll get over it. We know that it's more than that. Ang OA mo, girl, ha? Relax ka lang. No, because again, there is a strong biological component to all of these mental health conditions. What can you say? I'm here to help you. So let's do proper medical workup, and I will stay with you. I'll help you, and let me know how I can make you feel better. Now, speaking of anxiety attacks, as mentioned earlier, kasi kanina, they go to the emergency room na nag-hyperventilate, talagang fast, shallow breathing. This is a very important technique that ER doctors can help, can teach the patients to help them calm themselves. Take slow, deep breaths in through the nose, pause for 4 seconds, and out through the pursed lips, making sure that your patients get as much oxygen, inhale as much oxygen as they can to help bring more oxygen supply to our brain cells to lower down the levels of cortisol, adrenaline, diba? What I mentioned kanina, no? Yung adrenaline or epinephrine. Make sure that they fill their lungs, not just their lungs, with oxygen down to their belly. It should be belly. So kailangan they should feel the rise. Yung rise and yung pag how do you call that? No, belly out, diba? Because of the supply of oxygen coming in. Specifically also, never use the brown bag. We don't use that anymore because when we use the brown bag, yung technique dati pa, it will only accumulate more carbon dioxide. So what will happen? Carbon dioxide is a panicogen. So the more carbon dioxide which is accumulated in that brown bag, then the more the patient becomes more panicky, more anxious. So we don't use that. We use oxygen. Give oxygen instead directly. As ER physicians, specialists, please inquire about suicidal thoughts. One mortality from suicide is already a lot. And if we can avoid, if we can prevent it, please do. You can use this suicide tool, assessment tool for suicide risk. Males are more at risk. The younger or the more elderly are at risk. Those with symptoms of depression, the highest predictor for suicide, in fact, is previous attempts. Talagang you you need to ask this. Were there episodes of suicide attempts in the past? If they say yes, then that should really be a red flag na, yeah, there is a high probability that this patient may do it again. Alcohol use, impaired reality testing for those who are psychotic, organized plan, they have a specific method in mind, poor social support, and with medical problems. Make sure that you inform responsible authorities if the patient comes alone, kasi lalo na they're the young, diba? The youth. Sometimes they're scared to tell their moms, their guardians, their family. They don't, kasi usually they say na we don't want to be a burden, quote unquote. Know that you will be protected by the mental health law. It says that there under the Mental Health Act, there are provisions for concerned individuals such as family members to be involved. Involve the family. So involve the family, or if it's a school, inform the school, etc. It should be a collaboration to protect the lives of our youth. And for emergency cases, if you're unsure or if talagang you feel na there is a need to see a psychiatrist kaagad, immediately call the National Center for Mental Health. They have a crisis hotline. It's very easy to remember. It's 1553. On mental health, anxiety, and depression. Maraming salamat po, Department of Emergency Medicine, St. Luke's Medical Center, QC. You are all superheroes at the emergency department. Maraming salamat po.
Thank you so much, Dr. De Ferriel. Truly, it is a huge problem that it's a silent pandemic, because communication is the initial way we actually discover this, but it's also the hardest part.
Thank you again, Doctora. And we love the energy, by the way. Thank you so much. We love the passion in the lecture that you did. And please indulge us more as we go into our Q&A later to be able to accommodate the questions from our participants. Thank you again, Doctora. Thank you, Doc. So in line with this, a good clinician not only answers to the physical, but should holistically treat a patient, which is why we would like to highlight that the title of our series for this lecture is The Hidden Pediatric Pandemic, Mental Health and Behavioral Disorders. So for our next speaker, we have in our midst a gem in the field of pediatrics. She is a graduate of the Pamantasan ng Lungsod ng Maynila, where she has also trained numerous stellar graduates as an associate professor in pediatrics. She is the current head of the Pediatric Emergency Medicine here at SLMCQC and is the author of the Pedia Platinum. Having completed her master's in clinical psychology, our next speaker is more than qualified to share to us the commonly encountered behavioral disorders in the difficult adolescent. Ladies and gentlemen, a warm welcome please to Dr. Ruby Punong Bayan. Please be on standby. We're waiting for Dr. Punong Bayan to join us. Hello, Dr. PV, are you there?
Hello. A pleasant afternoon to all. Do you hear me now?
Yes, Doc, loud and clear.
Okay. Again, I'd like to greet everyone a good afternoon, and let me express my sincerest appreciation to my emergency medicine family in St. Luke's Medical Center for inviting me to their 28th annual postgrad course and talk about a very important and timely topic regarding adolescents and the peculiar manifestations of some behavioral disorders. peculiar yet commonly being manifested. Okay. Let me jumpstart by presenting this case. Just last year, there was an 11-year-old male who was brought by her mother to the ED because of hard to control agitated behavior at home. So apparently, the history was an acute manifestation of agitation being very hard to control. And there was tantrums. So you would think that at 11 years old, developmentally speaking, the tantrums should not have been really that common. However, upon a deeper investigation, a complete history showed that indeed there has been behavioral problems being manifested even months before, but it was just unfortunate that the parents weren't able to bring the child to the pediatrician or the primary caregiver or the doctor for proper assessment. So in time, the behavior became worse, and it's actually being hard, and they find it hard to control the temper of this case, the temper of this child. So this particular scenario paints or shows us different layers of possible behavioral problems indeed. Hence, my objectives for this presentation are to discuss the difficult behavioral scenarios in the ED involving adolescents, as well as to execute a plan of management for these behavioral disorders presenting in the emergency department. Let's take a look at our youth nowadays. This is data coming from UNICEF 2021, as well as WHO data. You've heard Dr. Perez Rifarial also citing recent statistics. We have observed that even pre-pandemic, there have been a significant, steady, but slow increase in behavioral problems among children and adolescents, even young children, yes. And UNICEF data stated an estimated 1 in 7 adolescents globally who experience mental health conditions, but many are not diagnosed or provided care in a timely manner. 50% actually of mental health conditions among adults emerge by age 14. And suicide, has been cited earlier also, is the 4th leading cause of death among adolescents and youth between the ages of 15 to 29 years old. Moreover, NHS is the data coming from England. Again, it shows a consistent pattern of increase in mental health disorders. The yellow bars are for boys, the blue bars are for girls, and the gray ones are for all sexes. So you will see again that there has been identification of mental health disorders starting as early as 6 to 10 years old, more for boys, but the statistic becomes different when we are talking about the 11 to 16-year-old, showing here that there are more girls being affected, and again, more of girls during late adolescence onto young adulthood. Similarly, there has been, they identified 1 in 4 17 to 19-year-old adolescents who exhibit behavioral and mental health disorders. This particular data came from University of the Philippines Population Institute in coordination with the Department of Health Study, done 2021, but it reviewed cases from 2013 up to 2021, again showing similar results, wherein there is definitely depression being identified during the 12 to 17-year-old age group, and again, anxiety being identified as early as 6 to 11 years old, and again, a whole range of behavior disorders being identified as early as middle childhood up to late childhood and entering adolescent period. Okay? And again, this is Philippine data. And back last year, UNICEF provided and published a study done, and they called it Mental Health and Psychosocial Support Systems and Services, showing again that there's greatest increase of mental disorders during later childhood and mid to early adolescence. Young adolescents in particular had a sharp increase in conduct disorders, depression, and anxiety, while older adolescents and young adults had predominance of depression and anxiety with rise in psychosis and even eating disorders. Girls were identified to have a larger burden of anxiety and depression, while boys, and as well as autism and ADHD. So again, this is just to show a consistent pattern of increase in mental health disorders as well as behavioral disorders among our youth. In fact, part of that study, the UNICEF 2022 study, showed again the percent of youth who have ever thought of committing suicide more than doubled between 2013 up to 2021. Again, of course, because of an underlying anxiety and depression, as pointed out by Dr. Rifarial earlier. And among these, females are twice as high as that of males. And the last slide here regarding statistics show again an increase, doubling the incidence of those who ever tried committing suicide. Okay, again, between the years 2013 to 2021, again, involving more of females, a sad reality. So you will see again that there's a whole gamut of behavioral emotional problems that adolescents have to contend with, aside from agitation cited by the case I shared earlier. There could be also, the spectrum could involve violence and even aggressive behaviors, and again, suicide. But again, there could be underlying anxiety and depression because of factors like they have been victims of child abuse and neglect, thereby manifesting some conduct disorders such as being runaways or even the extremes of fire setting. I know this may be not that common, but these are important to identify even in the acute setting. And this particular portion of the slide highlights the childhood psychiatric disorders that we have. Again, from basic anxiety, it could be generalized anxiety disorder, for which the DSM-5 criteria should be fulfilled. But there are other forms of anxiety. It could be panic or separation anxiety, and even social anxiety disorder, even phobias and post-traumatic stress disorder. Again, disruptive impulse control and conduct disorders, such as having oppositional defiant disorder, which eventually the case earlier, eventually the psychiatrist who I talked to, because the patient was eventually referred to the psychiatrist, eventually was diagnosed to have oppositional defiant disorder. But since there was poor control with the case, and there was delay in seeking for management and intervention, so the patient exhibited exhibited agitation and agitated behavior in the household, and thereby sought consult at our ED. And there could be mood disorders, substance-related disorder, and acute psychosis even. So again, in other words, we have to be aware and cognizant. We have to have a high index of suspicion, especially if the pattern is repeated or if there is continued behavior that disturbs others, meaning there is now strained relationships in family, in school, among peers, or maybe there could be sudden change in behavior or peer relations. And if there are excess of being overactive and being impulsive, of course, and changes in overall functioning of the adolescent. So to what do we attribute these behavioral problems? Again, we're talking of interplay of several factors, such as, of course, biological. It could be genetics. You could go deeper by eliciting during infancy or early childhood. Has there been significant head trauma? Okay, we look at the temperament and underlying physical illnesses. It could be social demographic factors, especially there are more cases identified among the low socioeconomic status or being young parents and have coming from or having a low educational level. There could be school factors again and family factors as well. How the family interacts and deal with their children. What are the family dynamics? This should be part of the investigation during our history taking. We look into the possibility of having adverse childhood experiences or ACEs. There have been numerous reports stating a direct correlation between the presence of adverse childhood experiences and the manifestation of behavioral disorders among our adolescents. So adverse experiences refer to, again, abuse in general. So were they are there red flags of possible abuse, either physically being abused, emotionally or verbally being abused, as well as sexual abuse? Were they neglected? And again, household dysfunctions like having incarcerated parents who maybe also are heavy drinkers or into gambling or doing substance abuse as well. So these are all factors to the presentation of the different behavioral disorders. Now, if you encounter an agitated adolescent in the ED, so here are basic principles to remember. First, we prioritize the safety of the patient and, of course, the treating staff. Okay? You look at the surroundings, whether we can identify a safe space for the patient. It is very good if your ED, if your institution has a separate room for this. Of course, not all institutions might have the space for this, but at least separate them. Try to find a corner a bed where you could separate them from the general population in the ED. Assist the patient in managing his or her emotions. I'll talk about that in a bit. And regaining control of his or her behavior. Of course, that entails a confident, a soothing tone coming from the ED physician, and then utilize age-appropriate and the least restrictive methods possible, and recognize that coercive interventions may exacerbate the agitation. So these are the 4 principles that you should apply whenever you encounter an agitated patient. Now, you may use chemical restraints or what we call medications to address acute agitation, of course. But you have first to identify what is your suspected etiology of agitation. Is it an underlying medical problem? Does the adolescent have a history of recent alcohol or even substance abuse? Of course, you can either get this from the adolescent, from the adolescent himself or herself, or maybe from the parents or whoever, the relatives who brought them to the ED. Okay, if this is the case, for mild to moderate severity, then we can give benzodiazepine. But if the agitation is really severe, we could use benzodiazepine first and consider adding an antipsychotic. If the suspected etiology of agitation is because of an underlying psychiatric illness, then you could either give a benzodiazepine or an antipsychotic for mild to moderate agitation. But of course, your choice should be an antipsychotic for severe agitation with a psychiatric illness. If the etiology of agitation is unknown, you still haven't figured out what really is causing the agitation, the recommendation is a dose of benzodiazepine or antipsychotic, and then consider a dose of the other medication if the first dose is not effective. Now we go to this, to the particular medications. So for symptom-based treatments, again, for anxiety, for adolescents, we could use midazolam. Okay, look at the doses here. This is what we follow depending on the age range. You could give this IV or IM with a maximum of 10 milligrams, of course, or if they can tolerate oral medication. For the ED physicians and also the nurses, the ED team, you should all be aware of the onset of action so that you will know what to do next. So you would expect that the onset of action of each of the medications, okay, so that the next step in the algorithm can be instituted. Like for example, for midazolam, the onset of action, if you give it IV, you should take note of the effect in about 3 to 5 minutes. If you're given it IM, it takes a little longer, of course, 15 minutes. Or you may use diazepam, okay, at these doses. Again, either IV or IM. For IV diazepam, of course, you could expect response within 5 to 10 minutes, okay, or diphenhydramine, 1 milligram per kilo per dose. The maximum is 50 milligrams. So even if your adolescent is quite heavy, like 60 kilos, 55 kilos, you still give 50 milligrams. That's the maximum. But of course, if you give diphenhydramine, you could expect the onset of action within 15 to 30 minutes. Now, if you're dealing with agitation, again, because of an underlying psychosis or a manic episode, say, you could, of course, give olanzapine. Your olanzapine is given at these doses. You could give it per ORM, or you could give risperidone. Olanzapine, by the way, it takes about 5 to 8 hours per ORM before the onset of action. While you could also give risperidone, it takes about 30 to 60 minutes before the onset of action, or haloperidol, the antipsychotic. Now, for impulsivity or maladaptive aggression, the recommendation is to give either risperidone or olanzapine, noting also or using the doses mentioned earlier. Now, what are the other strategies of de-escalation or trying to bring down the agitation level of the patient? Of course, you have to monitor and reevaluate the restrained patient from time to time, but verbal restraints can be used as de-escalation, okay? So you respect their personal space, you minimize the provocative behavior, like try not to use words that may further provoke or stimulate the already agitated adolescent. You may use neutral words like, can you share with me what is happening? But don't say, you are so misbehaved. Ang gulo-gulo mo dito, hindi ka mapigilan. Of course, these are no-nos. These are not professional ways of addressing the situation. You could establish verbal and eye contact with them, but be concise, no? And use active listening. You can say, what has been the problem? What is bugging you? I could listen. Can you share with me so I can help you further? Okay. By active listening, you may nod your head and you may use, okay, yes, what else? Okay, you may use these phrases. Or you could either agree with the patient or agree to disagree with the patient, okay? And offer choices and optimism. So these are some tips with regards to utilizing verbal restraints. For physical restraints, the international recommendation is, of course, use of at least five personnel in the ED, one for each extremity on the lower limbs and for the upper limbs, as well as someone to hold the head. That's why 5-point restraint. And then we use leather or age-appropriate restraints, and then we secure the restraints in the bed frame. Now, when do we use physical restraints? Of course, if there is an imminent risk of harm of self or to others, if there's a significant risk of disrupting the treatment, and of course, if the less restrictive means have failed. Halimbawa, hindi siya na-appease using your calming, soothing tone to de-escalate the situation. Hindi kaya ng verbal restraint. Hindi rin kaya ng medications or chemical restraints. This is, of course, the last recourse. But once the patient is restrained, you also have to follow certain international protocols, like what has Joint Commission requirements on evaluating and ordering restraints have cited. If you have a licensed practitioner in person, that is the physician or the nurse, that is the person to evaluate the restraint. Like, these are the age groups and how frequent it is that we should evaluate the restraints, like within 1 hour of placement of restraints. This goes for all ages among children and adolescents. And then if we need to renew the restraint order by qualified staff, kasi di ba we are monitoring, observing, doing some laboratory tests every hour for less than 9 years old, every 2 hours for 9 to 17 years old, and every 4 hours for more than 18 years old. And again, evaluation to renew. Kailangan pa ba ulit yung restraint order? So if the patient, should there be any reason for them to stay longer in the ER. We know that the average stay in the ER should be 4 hours, the turnaround time. We should have already our decision as to whether the patient should be admitted or sent home. But if there is, like, some unforeseen circumstances, waiting for a room, waiting for the attending doctors, so we should reevaluate them still while at the ED. And assessments every 15 minutes for all ages would include, of course, taking the vital signs, looking for signs of injury, looking at their state of hydration kasi naka-restraint sila, no? Looking at the circulation status in the extremities and the range of motion too, and how about their bowel and bladder elimination, and offering them psychological comfort and evaluation too for readiness to remove the restraint anytime. Here are a few more cases, a couple more cases. There was a 16-year-old female who was brought to the emergency department because of seizure. I believe that this was encountered early this year or maybe late last year. So apparently, the history of this adolescent female was that he had frequent seizures daw, okay? Noted by the parent at home. Na there was apparent contraction or stiffening, tonic movements, which of course is stiffening of the extremities, as well as jerking movements, so tonic and clonic movements, okay? And for which they sought consultation, of course, at the ER. So of course, we admitted the patient, and during extensive history again, we found out some risk factors for possible behavioral disorders. Di ba yan yung lagi nating ina-emphasize? We consider first an underlying medical problem, such as if this is seizure, then we might establish, of course, seizure disorder or epilepsy. But we need to eliminate these medical conditions before we start to think of or to consider a possible psychiatric or behavioral problem. Fast forward, apparently this patient had what we call just recent, I think a week ago. And guess what? The onset of the palpitations was 3 years ago. The parents were, what we call, quote unquote, doctor shopping, hospital hopping, looking for other opinion, seeking for third, fourth, fifth, nakailan na, I don't know, fifth opinion regarding the palpitations. And they were already cleared by a cardiologist as well as an endocrinologist. Okay? So the palpitations still are there. So what do? Of course, even in the ER, we try to investigate. We do extensive history regarding this, the concerns of this particular adolescent. So I'll mention again what happened to this adolescent male in a while. So what is the challenge here? For us, in the emergency department, it is the recognition of clinically challenging mental health conditions presenting with medical or uncertain symptoms. So it could be, again, a range of pseudoneurologic symptoms, pain symptoms, even GI symptoms, and of course cardiopulmonary symptoms. In fact, no, dito nagfo-fall yung kanina, no, yung adolescent female may seizure, tapos yung adolescent male palpitations naman. But you can see here, this could be of course explained by a medical problem. Once we rule out, we establish that there is no underlying medical condition to answer the problems of these manifestations, we start now considering behavioral and even psychiatric problems. DSM-5 actually recognizes 7 distinct somatic symptom and related disorders. And this is somatic symptom disorder, illness, anxiety disorder, we have conversion disorder, psychological factors, and down the line. We even have factitious disorder there. Okay, and each disorder has specific diagnostic criteria. It can be applied to situations in which the level of distress or disability is disproportionate. The word is disproportionate to what is typically associated with the physical findings. And would you believe that there has been 10% of adolescents reporting headache, recurrent abdominal pain, chest pain, and fatigue? This has been cited in studies and published in the Journal of Adolescent and General Psychiatry by Barsky et al. And then they use, this particular adolescents use all types of medical services. Ito nga yung hospital hopping at saka clinic hopping. So primary care, the emergency department, even mental health care, they tend to utilize all of this. And again, they are more likely to doctor shop. Now, going back to the adolescents, again, the one that I told you about pseudoseizure, which, by the way, the current name for that condition in DSM-5, okay, the Diagnostic and Statistical Manual for Mental Disorders, is called PNES, or psychogenic non-epileptic seizure, wherein the gold standard for diagnosing this is using video EEG to show that there is compatible history. And several authors, again, have in fact cited that this particular patients who had PNES all had multiple previous ER visits. They were prescribed anticonvulsants. They were even admitted in the hospital for further diagnostic testing. And the seizures resolved after psychiatric treatment. What's also very important to note here is the type of seizure being manifested by these adolescents with PNES. The seizures consistently were described as waxing and waning consciousness, out of phase shaking movements, and there could be side to side head shaking and eye closure. But take note, with regards to eye closure, the eyes were described as tightly closed with resistance to eye opening during an event, which is inconsistent of a true epileptic disorder. And this particular characteristic or manifestation of the eyes being closed, tightly closed, has been a reliable sign of PNES in about 95% and has been cited in neurologic textbooks. Okay, and especially the mouth, you could also take a look at the mouth of these patients with PNES. It is usually open during the tonic phase or during the contracting of the muscles of the limbs, the tonic phase of a generalized convulsion. Naka-open siya. So kung tightly closed din ang mouth, ayaw niya ibuka, tightly closed din ang eyes, then yes, it could probably be PNES. For somatic symptom disorder, this is the problem of the adolescent male that I told you about earlier. So DSM-5 criteria states that there is one or more somatic symptoms that are distressing. There are excessive thoughts, feelings, or behaviors related to the somatic symptoms manifested by at least one of the following. Again, disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about symptoms, excessive time and energy devoted to these symptoms, and guess what? State of being symptomatic is persistent. Pasok talaga sa timeline yung teenager na sinabi ko. More than 6 months sa DSM-5 siya. 2 years na ba? 2 years na ang sinabi sa amin. Okay. So again, important to identify in these somatoform disorders or somatic disorders are if they are vague, poorly described complaints, recent or current stressful events. It could be from home, from peers, in a relationship, school, community. Symptoms that fluctuate with activity or stress, and lack of physical findings and laboratory findings as well. Now, the question of, can we use mental health screening tools? Is it feasible? Is it allowable, feasible, and practical to do in the ED setting? Several rapid, efficient, and accurate ED mental health screening tools have been developed and utilized. And yes, studies have shown that the emergency department is an ideal setting for screening high-risk, difficult-to-reach pediatric populations with mental health problems. We know that there is clinical and time pressures of the ED setting. So is this really acceptable to adolescents and their parents and even the ED doctors? Do we really should do this? The answer again is yes, because numerous studies have shown their acceptability. I'd like to share with you 3 of these common tools. One is what we call HEADS ED. For pediatricians like me, HEADS, the version HEADS with 3 letter S's has been revised for emergency department use, wherein now you have to ask pertinent questions regarding the home to identify risk factors why there is a possible behavioral or emotional problem among these adolescents. So how are you at home? Are you close to your parents? Where are your parents? Who do you live with? Okay, ilan kayo? Ilan ang siblings mo? Okay, questions like that. Education, anong grade mo na? What subjects do you enjoy? Kumusta sa school? Okay, activities, what are your hobbies? Okay, drugs and alcohol, of course, have you tried? Especially we're dealing with adolescents here who are risk takers. Have your friends, do your friends drink? Diba? Ang advice nila, ask first the friends, no, yung sa paligid, before you ask the adolescent himself or herself. Have your friends tried? Have you tried? Binigyan ka ba? Okay. Suicidality, of course, emotions, behaviors, and thought disturbance to identify anxiety and depression, and discharge resources, meaning who's taking care of you? Have you sought help? Meron ka bang mapupuntahan na help? Okay, are you aware na pwede magpunta sa pediatrician and or sa psychiatrist? Okay, so these are questions regarding discharge resources. So you can see here that the most number of points that you can assign per area is 2. And because there are 7 areas, of course, the highest score is 14. But the utilization of this tool says if you scored more than 7, then of course this is associated with really problematic adolescents who need further intervention and management. Another tool is what we call suicide risk screening. So there are 4 questions here. By the way, all of these forms are downloadable for free in the website. All you have to do is type in the Google search box suicide screening questions in the ED and HEADS ED. Okay, so going back to ASQ or Ask Suicide Screening Questions, there are just 4 questions answerable by yes or no. In the past few weeks, have you wished you were dead? Have you felt that you and your family would be better off if you were dead? Have you been having thoughts about killing yourself? And have you ever tried to kill yourself? So any yes to these questions again needs stat immediate safety and full mental health evaluation, call in the psychiatrist, no? And there's another one tool here. I know that Dr. Perez Rifarial also cited several tools here. Of course, you could also use this. This is for identification of depression among adolescents, which we call Patient Health Questionnaire 9, because there are 9 questions. If you go through the questions here, you will note that all of these are, in fact, the definition of major depressive disorder cited in DSM-5. Okay, so questions like, are you feeling down, depressed, irritable, or hopeless, or do you have little interest or pleasure in doing things? So the scoring is not at all, several days, more than half the days, and nearly every day. So again, scores of 10 to 14, there is now already mild, even to moderate depression, and 15 or more, of course, is very problematic. Again, needing further intervention and immediate intervention at that. Okay, so in summary, I've cited the common symptoms that are part of somatic disorders and other behavioral disorders among adolescents, and that there is timely utilization of appropriate and different kinds of restraints in the ED setting, and that mental health screening is a vital part of the management of behavioral disorders.
Thank you very
My
much.
last,
Dr.
okay, my last slide is everything worth doing in life requires effort and commitment, which means that what we do in the ER is a constant updating of ourselves regarding what should be identified and how should we go about it, especially for behavioral and mental health disorders. So of course, whatever we do, because we do it with all our hearts and our time and our minds, it requires indeed effort and commitment. Thank you for your kind attention.
Thank you, Doc. Thank you, Dr. Punong Bayan, for your time and for that very engaging lecture.
Truly, when it comes to difficult pediatric patients, the phrase "patience for your patients" comes into mind.
So for the interest of time, the questions raised earlier for addressed to Dr. Refarial, she was already able to answer those. And for those questions directed to Dr. Punong Bayan, she will be able to the questions are already noted. We will just forward it to her for her to be able to accommodate those. So we may proceed now with the awarding of the certificates.
Okay. This certificate of appreciation presented by the St. Luke's Medical Center, Quezon City Department of Emergency Medicine is proudly presented to Dr. Ruby Punong Bayan for sharing her expertise during the virtual conference of our 28th postgraduate course entitled ENSEMBLE, Concerted Efforts, Outstanding Outcomes, held on the 21st of July, 2023 via Zoom conference, undersigned by Dr. Rhea Guntalilib, Postgraduate Course Director, and Dr. Arnel Tolosa, Department Chair.
Thank you.
And this certificate appreciation is also presented to Dr. Joan May Perez Refarial.
Dr. Refarial has a prior engagement, so she already left after engaging with the questions raised in our chat. So before we approach the last part of our lecture series, we would like to hear a message from our sponsors for now.
Just like healthcare Incorporated, your partner in healthcare. Excellent service and excellence introducing just like patient care. Personalized, personalized, 300
QR code for the post-test. Okay. Just a gentle reminder to answer our pre-test, and the QR code for the post-test and evaluation form will be posted at the end of the next lecture.
Again, be sure to be able to accomplish both the pre-test, the post-test, and the evaluation form for you to be able to be granted your e-certificate.
Okay. As much fun as we've been having, as much fun as we had having you all today, sadly we are on the closing stages of our course. But don't worry, since we save one gem to impart with you today. As EM practitioners and allied health professionals, our work should not be limited within the walls of our emergency rooms. We should also be socially aware and advocates of equality.
We at SLMC are all about inclusivity, which is why we are more than fortunate to have with us today our keynote speaker to add more color to our social lenses as he talks about the diversity and inclusion in terms of transgender care in the ED. Dr. Santos is a graduate of the Far Eastern University NRMF, and he finished his residency training as the chief resident at Pasig City General Hospital. He then went on to further his craft by training for pre-hospital emergency care at Singapore. He is the former president of the Philippine College of Emergency Medicine and is the board director of the Asian Society of Emergency Medicine. Everyone, please give it up for Dr. Richard Henry Santos.
Hello, good afternoon, and thank you very much for that introduction. I know it's already late in the afternoon, and this is the last lecture, but I hope our listeners still has the energy, no, para matapos yung ating last lecture. Let me share first my screen. All right. So can everybody see my screen now?
Yes, Doc.
All right. Okay, so once again, good afternoon. My name is Dr. Rich Santos, and my pronouns are he and him. I would like, of course, to thank the organizers of this conference for inviting me to speak about a topic that is very close to me and as personal advocacy. So I have no financial disclosure in relation to this presentation. And before I proceed to my lecture, I want to share with you this news clip, which I came across way back in 2019. In this unfortunate event, a nurse working in the emergency department committed the mistake by assuming that the patient, who happens to be a transgender man, is male. Now, to summarize, the patient was a 32-year-old man who presented with an 8-hour history of abdominal pain. So the nurse triaged this patient as a non-urgent case, and later on, when the patient was assessed by the emergency physician, he was not only found to be gravid, but also in labor. So later on, nanganak siya, no? And the baby was stillborn. This case was actually also presented in the journal of the New England, no? So pinakita rin doon, it was used as a case study to show how much the learning gap or the gap between what we should know and how we provide care to our transgender patients. Okay, so this will be the outline of my presentation. First, I will define some key terms and concepts related to transgender people. Then we will describe the major health and healthcare disparities facing the transgender community, summarize how to make clinical environments more welcoming to transgender patients, and finally, we will review transgender-specific emergency care topics. So as providers, we should be aware of basic terminologies used by the trans community, in addition to what I will be presenting, which is largely based on the North American language, English language. The healthcare provider should also be familiar with the local or individual terms that may exist in their communities. Take note that some definitions may change over time. So first, we begin by differentiating the two terms, sex and gender. Although sometimes or most of the time we use them interchangeably, they mean different things. For example, to be more specific, sex would refer to your biologic characteristics. It has something to do with your biology, while gender is a social construct. Persons typically have their sex assigned at birth based on the physiological characteristics, including their genitalia and chromosome composition. So, say for example, we have a baby who was born with a penis and testes. They are assigned male at birth, while those born with a uterus and ovaries are assigned female at birth. But for us in the medical field, we know for a fact that sex is not always male and female because we have of course in development of their sexual organs or some chromosomal abnormalities. So some babies may have bodies or chromosomes that don't fit the typical sexual construct. Gender is really defined particular society of how a male dress, look, behave, and conduct them. The concept of gender because it can change over time as well, and different societies have different social contracts for each type of gender. And then we explore aspects of more important is your gender identity. Gender identity is each personal and individual experience of gender. It is being a woman or a man or both or anywhere along the gender spectrum from their sex assigned at birth. Gender expression, meanwhile, is how a person publicly presents their gender. This can include behavior and outward appearance, such as dress, hair, makeup, body language, and voice. And finally, sexual orientation. Sexual orientation is a separate concept to describe one's patterns of emotional or romantic or sexual attraction. It is about who you want to be with as opposed to gender identity, which is about who you are. So examples of your sexual orientation, if a male gender is attracted to another male gender, that is homosexual sexual attraction. If a female is attracted to a male, that's your straight or heterosexual sexual orientation. And then if you're, for example, attracted to both genders, you can refer to them as bisexuals, or if the person is attracted to all types of genders, we can also refer to them as pansexual. So as previously stated, gender is not neatly divided along the binary lines of man and woman. For example, some people do not identify with any gender, while others identify with multiple genders. Only the person themselves can determine what their gender identity is, and this can change over time. The term cisgender is used to describe an individual whose gender identity and expression matches the stereotypical societal characteristics related to the sex assigned at birth. Those with transgender or gender non-conforming life experiences or history have a gender identity different than the gender assumed at birth. Okay, so this table basically just illustrates how complicated things can get now when you combine your gender identity, your gender expression, your sexual orientation, and your sex assigned at birth. So say, for example, we have someone who was born male at birth who transitioned to become a transgender woman, but then is attracted to another woman. So you would label that as a homosexual or lesbian orientation identity. So you can see here that there are different iterations on how human sexuality can operate. Take note that since 2019, the World Health Organization has declared that gender incongruence or being a transgender is no longer classified as a mental disorder. However, gender dysphoria is considered a medical disorder. Some people who are transgender will experience gender dysphoria, which refers to psychological distress that results from an incongruence between one's sex assigned at birth and one's gender identity. And according to DSM-5, this is the marked incongruence between their experience or expressed gender and the one that they were assigned at birth. And sometimes, no, these feelings can be so intense that it can produce depression and anxiety. Transitioning is the process that many transgender people undergo to bring their outward gender expression into alignment with their gender identity. Sometimes, no, they can undergo some social transition, for example, by changing their names, changing pronouns, and their clothing, but they can also prefer to use medical transition, either through the use of hormone therapy or undergoing surgical procedures. So let's now talk about trans healthcare disparities. For most of us, or for some of us who need to visit the emergency room, sometimes it can already produce some form of anxiety. However, for our transgender patients, the experience can be even more harrowing. No? Gaps in staff knowledge about gender health can contribute to patients' uncertainty about receiving prejudice-free and competent care. So this is a recent study published only this year, trying to estimate the incidence of being a transgender globally. No? In this study, they found out that 1% of the global population would identify as transgender, and 1% would identify as non-binary, gender non-conforming or gender fluid, and 1% of the global population would identify as neither. So they are neither a male or a female. Take note, though, that the estimation of the population of transgender people is, of course, medyo mas mababa because a lot of people would choose not to reveal their gender identity to the public. And as we know, no, dahil konti lang talaga sila within our population, transgender individuals belong to a marginalized segment of the society. Overall, the transgender population experience various health disparities, and without adequate access to equitable healthcare, this vulnerable population is potentially susceptible to a multitude of adverse health outcomes. So from studies, we have documented that transgender patients have higher risks for poverty, depression, anxiety, substance abuse, sexually transmitted diseases, and cardiovascular diseases. In the emergency department, no, this is a study published in 2014, done in Canada. In the respondents who were transgender patients or transgender people, 21% of them have reported that they avoided the emergency department even if they need emergency care. And 52% of the respondents even said that they experienced trans-specific negative ED experiences. 32% said that they were subjected to insulting language, and 10% were even refused care just because they were transgender. And this another study, they tried to figure out what are the reasons why our transgender or gender non-conforming patients would not visit the emergency departments. And some of those that were listed in that study was that of their past personal experience while visiting the emergency department. So in the past, when they experience a bad service, for example, di sila babalik in the future. And another thing that they listed here is the patient-provider encounter. No? Most of them noted that the healthcare provider is not experienced or is uncomfortable in providing care for transgender patients. So as frontline ED staff, we have the opportunity to make patients feel welcome in the emergency department. So we should establish a welcoming and gender-affirming environment. So when we do our history taking, do use the pronouns that match patient's gender to address the patient chosen pronoun. But it may not be always possible because correctly determining the pronouns based on the individual name can sometimes be misleading. So for us to know that, kailangan natin gender identity and the gender and the sex of the patient. No, so first, this is actually suggested to be placed on your or your for your medical record. No, first you ask what is your current gender identity. So you list down all types of gender identity, and just to make sure that you haven't missed anything, you can place here yung others to allow the patient or to allow them to identify their gender. Next, and then you ask them what is your sex assigned at birth. No, so pwedeng male, female, and others. And then finally, you can ask now, ano yung kanyang preferred pronoun. Take note that we should use this pronoun all throughout your encounter. So why are pronouns important? Pronouns are important because using a person's pronouns correctly, other people are showing them respect and forming an inclusive environment. And moreover, use of their chosen name and multiple contexts affirms their gender identity and reduces mental health and risk known to be high in this group. So this table again just shows you how to your comprehensive gender identity information. So again, you ask for gender identity, and then use the sex listed at birth or listed in the birth certificate, and then you can ask finally the pronouns. And take note that some would use different types of pronouns. So hindi lang he, she, him, hindi lang yung mga yon na ginagamit. Sometimes they can also prefer to use they or them. Itong ze or zir, see or hear. So these are pronouns that are sometimes used in Western countries. And because there are many different gender expressions, we should avoid using binary language that assumes that there are only two genders. No? Use of all genders instead of both genders, opposite sex, or either sex. If referring to biological sex alone, use female, male, or intersex. So for example, if you want to ask if, say for example, are you the mother of this person? You would rather say, are you the parent of so and so? Instead of asking, where is your husband? You can ask, where is your spouse or partner? So some more points when doing your history taking. Do not ask questions about anatomy and genitalia that are not relevant to the encounter. We should keep our questions open-ended, and whenever possible, allow the patient to describe themselves in their own preferred language. Next, do not ask questions that will not directly impact guidance, medical decision-making, or management. And it is important that every time you ask a question related to, say, for example, their gender identity or the procedures that they went through, or if they are taking hormonal therapy, explain why you're asking certain questions. And finally, once you are able to get these answers, do not disclose a person's trans status to anyone who does not explicitly need to know. So I heard of this example, no? This happened in a private hospital here in Manila. So a transgender patient was seen in the department, and then tinatanong niya dun sa doctor, is there a possibility that my record can be changed? Kasi sabi niya, she is a trans current boyfriend, and she cannot appear in the receipt or yung parang statement of account kasi my boyfriend will be paying for, siya yung pupunta dun sa cashier to process the papers for my discharge. And obviously, in the Philippines, we know for a fact that changing or we don't acknowledge the changing of sex or gender in our legal documents. But in the hospital setting, we should be able to put up a compromise between keeping allowing our patients to be able to be more comfortable, and also keeping their legal identities also secured. So what we can do here, for example, pwede kang merong parang markers na lang or parang identifiers. Instead of putting on documents that this person's name is so and so, as well as the gender, no, parang and sex. So mas maganda kung meron tayong opportunities to be able to do that. So for physical examination, as healthcare providers, we should be aware that secondary characteristics might be present or partially present or not present at all, and injury and or using hormonal therapy. And don't forget to ask if the patient would like to have someone in the examination room. This can be a person who came with him or her, or we can have a patient we can have a member of the staff join you in the examination room. It is important that we discuss all the steps of the physical examination beforehand, and remember to say or to state to the patient that if at any time they feel uncomfortable during the examination, you can stop. And finally, you might also want to consider using an anxiolytic before performing an exam. So let's now talk about trans-specific medical issues. So gender-affirming hormone therapy is the primary medical intervention sought by transgender people. Such treatment allows the acquisition of secondary sex characteristics more aligned with the individual's gender identity. So some patients would choose to do hormonal therapy alone or combine them with surgical therapies as well. So for feminizing hormone therapy, we can use estrogen and anti-androgens such as spironolactone. And for the masculinizing hormone therapy, the mainstay is the use of testosterone. Take note that there are adverse reactions and complications with the use of your hormonal therapy. For your feminizing hormone therapy, the risk for was parang more than 5 times ata based on the current documents. Another complications with the use of your feminizing hormone therapy or your estrogen is that there's a moderate increase in the incidence of cerebral ischemia, cardiovascular complications, hypertriglyceridemia, increase in liver enzymes, weight gain, and regarding its effect on some cancers, it is not well established, such as your breast cancer and prostate cancer. As to your masculinizing hormones, the most obvious effect that is being documented is that there is an increase in your RBCs or your erythrocytosis, leading to the condition of polycythemia vera. And other effects would include weight gain, increase in liver enzyme levels as well, hypertension, and cardiovascular complications. Take note also that some medications can interact with other drugs. Like, for example, your estradiol can interact with your anticonvulsants, anti-infectives, thereby decreasing the effect of your hormonal therapies. Even your testosterone can interact with anticoagulants. Also, when we are interpreting laboratory results for transgender patients, it is important to take note of the possible effects of using hormonal therapy on our lab values. For example, the hematocrit for patients receiving estrogen might be decreased, while it is increased in patients who are taking testosterone. And for those who are taking estrogen, the creatinine can be decreased. And for those who are taking masculinizing hormone, it can be increased. So marami siyang kailangan i-consider. We should use this in interpreting our lab values. So another condition specific to transgender patients, specifically for transgender men, is the use of binding. Binding is performed by a transgender man, with the use of tight-fitting sports bra, shirts, or bandages to provide a flat chest contour. So some complications of this would include skin tears, skin infections, sepsis, back pain, shortness of breath, costochondritis, and anxiety attacks. For transgender women, what they usually do is tucking. This is the process of moving the penis and the scrotum as well posteriorly into the perineal region. And the complications of this would include penile or scrotal pain, inguinal herniation, skin tears, skin infections, balanitis, and infertility. There's a wide range of gender-affirming surgeries available. No? Some of them are specific to trans patients and some of them are not. Like, for example, yung specific to trans patients would be your sex reassignment surgeries. No? O tinatawag natin bottom surgeries. So for trans male, what they would do is their phalloplasty, and for trans women, they will have their vaginoplasty. And then for the procedures that are not trans specific, we have your breast augmentation, for example, your facial feminization, voice surgeries, for example. These procedures are not specific only to trans patients. So what are the complications of your surgeries? So general complications would be intraoperatively, there's increased risk of VTE and pulmonary embolism, and of those who undergo chest surgery would have necrosis in the nipples, and in any forms of genital surgery, the chances of getting urinary tract infection is also high. So some specific complications for surgeries male to female would include wound dehiscence, necrosis, formation of fistulae, stenosis and retention of urinary retention, a constricted introitus, as well as complications due to bowel segment resection in intestinal vaginoplasty. For a female to male surgery, you can also have stenosis and fistulae, necrosis and persistent discharge, and abscesses in patients with incomplete vaginectomy. What is the management for patients who underwent surgery and present to your emergency department with complaints related to their surgery? Remember that patients may be sensitive about their examinations. Be cautious with the tissue in these surgical sites because they can be friable, and excessive manipulation can cause damage to the vessels, nerves, and skin. So, and we should also avoid using a speculum when we try to examine the neovagina, unless it is deemed both necessary and safe. And if the patient still has uterus and ovaries, it is important for us to do or perform a beta HCG test, no? Like for example, yung case natin kanina, when kahit na siya ay trans male, given the fact that the patient still has uterus and ovaries, we should still perform a pregnancy test. And finally, we should attempt to contact or refer back the patient to the performing surgeon or another local surgeon with expertise in this area. From what I know, most patients in the country would receive their sexual reassignment surgery from another country. So sometimes, pagpunta nila dito, they would need additional care. Dito nakikita that we lack knowledge or education in the management of these cases. Okay, so some take-home points. Remember that sex and gender are not the same. The transgender population is vulnerable within the healthcare system, and that as healthcare providers, it is our role to ensure inclusivity and access to emergency care. We should always ask and use the correct pronouns at all times, and consider complications of gender-affirming therapies in the assessment and management of transgender patients. So I think that was my last slide, and thank you very much.
Thank you very much, Doc Rich, for that very interesting lecture. And we appreciated that your first slide started with pertaining to your pronoun, to use he or him, because we were able to attend a conference also with Dr. Santos, an international conference, and there actually it was highlighted by there was a transgender panel amongst us, and then they actually highlighted the use of pronouns in terms of addressing them, and they really said that it mattered a lot to them in terms of approaching them and treating them.
Just the simple fact of normalizing these individuals' identities is a huge part in accepting them and making them feel more safe.
So we now proceed to the Q&A. We just have one question for Dr. Santos.
Around dead naming and appropriate pronoun use in the emergency department.
Okay. So actually, the solution to that is systemic. Dapat we should also the hospital should be involved in the process. Of course, kasi lalagyan natin ng opportunities for the person to have a blank space to include what is their preferred name, and preferred pronoun. So, for example, if you're using an electronic health chart, dapat meron din siyang blank na that would allow them to fill that out. So parang yun yung ating kailangan gawin. It will start from the administration to allow that change. But of course, as doctors, we also should not disqualify their sex, no? Kasi as we know, these are determinants of sexual behavior, no? Which is related to, of course, to how we manage our patients. We were taught in the past, no, we should recognize patterns. Some cases or some conditions are more common in males and females. So important pa rin as medical practitioners that the sex is there. However, hindi natin siya kailangang ipangalandakan to other people or those who do not need to know that this person is a transgender person. So kailangan meron tayong opportunity to write their real name and their sex at birth, and then another line which would allow us to put in their preferred name and their preferred pronoun and their current gender identity.
Thank you, Doc. We agree that it actually goes hand in hand in terms of using the preferred pronoun to build rapport to your patient, but at the same time, we take into the account the sex for us to be able to properly initiate the appropriate management for your patients. For the other questions, you may post them in the chat, and we will forward them to Dr. Santos if there are still any.
And now, just gently reminding you that we need, of the requirements to answer the pre-test, the post-test, and the evaluation to receive your e-certificate.
But first, we will proceed with the awarding of the certificate for our keynote lecturer.
St. Luke's Medical Center, Quezon City, Department of Emergency Medicine presents this certificate of appreciation to Dr. Richard Henry Santos for sharing his expertise during the virtual conference of our 28th postgraduate course entitled Ensemble, Concerted Efforts, Outstanding Outcomes, held on the 21st of July, 2023 via Zoom conference, undersigned by Dr. Rhea Guntalilib, Postgraduate Course Director, and Dr. Arnel Tolosa, Department Chair.
Thank you very much.
Thank you,
Thank you,
Dr.
Doc.
Santos, for your time. So again, we would want to remind all of you that after being able to accomplish the post-test and the evaluation form, that's the time that you will be able to be granted the e-certificate. At the same time, for our bonus, again, we just wanted to emphasize that we have a raffle, and we already picked pre-assigned runners, but unfortunately we will be telling you if you're the one chosen via email or text message. We will definitely update you on that. And then before we close the program for today, we would like to hear from our sponsors first.
Epilepsy affects around 50 million people worldwide, making it one of the most common neurological diseases globally. Nearly 80% of people with epilepsy live in low and middle income countries. 3/4 of people with epilepsy living in low income countries do not get the treatment they need. In the Philippines, the estimated prevalence of epilepsy is 0.9%. Epilepsy care is difficult to get hold of due to socioeconomic challenges and healthcare inaccessibility. As a
related disorders, we offer Omron, Algernon, and GI Core. The most trusted proton pump inhibitor brand today, Omron is prescribed by more doctors and remains a cornerstone in the treatment of GERD and various acid-related disorders. Omron is available in 20 milligram and 40 milligram capsules and 40 milligram vial. Overcome acid. Optimize relief with Omron. Algernon, an acid neutralizer with a combination of 3 effective components to rapidly treat the symptoms of acid reflux and hyperacidity. Sodium alginate, sodium bicarbonate, calcium carbonate. Versus other brand, Algernon also offers 25% savings and comes in a sweet peppermint flavor. Algernon, triple strong for rapid acid relief. To normalize the GI tract from dysmotility due to dyspepsia, we offer Domperidone GI Norm, the GI normalizer. GI Norm doesn't cross the blood-brain barrier, so there is no fear of CNS side effects. We offer Hyos. Hyos aids in smooth muscle relaxation and provides fast relief from abdominal spasm in as fast as 15 minutes at a more affordable price. Take a fast break from abdominal spasm with Hyos. For constipation, we bring you Moflax and Surelax. Constipation is a condition that can destroy one's everyday life. Westman's 2 laxative products are AC recommended. With Moflax, sufferers of constipation and hepatic encephalopathy can let go with no worries. Promotes regular bowel movement and is the only lactulose brand with taste right technology for worry-free compliance. Let go with no worries. Another premier choice in the management of chronic constipation is polyethylene glycol Surelax, the first unflavored laxative that can be combined with any beverage. Surelax helps improve stool frequency and consistency to provide relief for chronic constipation. Sure relief from constipation. For hemorrhoids and chronic venous insufficiency, Dioxol. Dioxol is the SOP in the treatment of grade 1 and 2 hemorrhoids and chronic venous insufficiency. Compared to other brands, Dioxol also offers patients as much as 19% savings. For amoebiasis, Westman Gastrocare offers Daziment. Daziment aids in the treatment of amoebiasis and various infections.
And since we concluded the last part of our lecture series for today, the link to the post-test and evaluation form is now open.
It has been a real pleasure in hosting all of you today. It's also been a real pleasure doing this with you, partner.
Me too, partner. We would like again to thank all of our esteemed speakers, our wonderful audience, and of course, our generous sponsors for making this activity a success.
And that wraps up this year's 28th postgraduate course entitled Ensemble,
Concerted Efforts,
Outstanding Outcomes.
Thank you very much. And for those registered and will be joining us for the Day 2 Refocus course, we are looking forward to seeing you.
Recording stopped.